My name is Dr. Nongiwe Lynette Mhlanga. I'm going to talk to you about the interventions to reduce type 2 diabetes amongst people who are aging, who are living with HIV. This study was conducted in Harare in Zimbabwe. People who are living with HIV have been living longer because of the effectiveness of antiretroviral therapy. And because of this effectiveness of antiretroviral therapy, people who are aging with HIV are now prone to chronic age-related chronic conditions such as type 2 diabetes. Among the older people living with HIV, the risks of developing type 2 diabetes are increased because they face the same risks as the general population. That is, you don't exercise, you live a sedentary life, and you eat unhealthy food, which is mostly carbohydrate and fat. That's what everybody else faces in the general population. However, because of HIV and the use of antiretroviral therapy, we find that people who are living with HIV have got excess risks to type 2 diabetes. And because on top of having excess risk to type 2 diabetes, this problem is particularly prevalent in sub-Saharan Africa, where HIV is a very common illness, and is the most of the countries have got HIV as the main chronic illness, especially among the young people or people who are aging. And the current interventions to reduce diabetes are only targeted at the general population. They don't take into consideration the excess risks that people who are living with HIV have been encountering. Therefore, it was important for us to conduct this study because of these excess risks that people who are living with HIV are facing. This study was conducted in a densely populated, low socioeconomic area from 5 primary healthcare clinics in Harare in Zimbabwe. Zimbabwe is a country within sub-Saharan Africa. And the methods that were used was a qualitative multi-method approach, which was applied with an exploratory descriptive research design. This was triangulated with an integrative literature review. This created 3 data sources. So for the exploratory descriptive study, we collected data from 2 sources, which were purposively selected. The first were all the people living with HIV, and the second were nurses providing care to all the people living with HIV. We used Whitmore and Nuffels framework for the integrated literature review, which generated the 3rd data source. Now, expanding on the method, Whitmore and Nuffels framework followed 5 steps. These steps, the first one was to identify the research problem. And we just looked at the research question, which was what guidelines can be used for the reduction of type 2 diabetes amongst all the people living with HIV. The second step was to conduct a literature search. This included studies from 2013 to 2023, which were in English from 3 databases, PubMed, Sinnerhill, and the Cochrane Library. And the key search words we used were diabetes, people living with HIV, and reduction. And literature search was done from the 22nd of May 2023 to the 17th of June 2023. The 3rd step was to define the information that we ought to extract. The information extracted included measures for screening for type 2 diabetes, secondly, health education, and 3rd, pharmacologic interventions to reduce type 2 diabetes. The 4th step was to evaluate the data sources. The critical appraisal skills program, CASP checklists were used, and we selected 3 different types of checklists. The first were the systematic reviews checklists, then the cohort studies, and the clinical trials checklists. And our data sources all were of good quality and 2 were of moderate quality. The last step was to interpret the findings. Microsoft Excel was used to describe the study year, the authors, the objectives of the study designs, the outcomes of the study. and thematic analysis was used to synthesize the study findings. Lastly, from the three data sources triangulation was applied to analyze using Brown and Clark's content analysis, the 2005 edition. Ethical approval was obtained from the University of South Africa under 140-57639 CREC CHS 2022. The results indicated that a total of 23 older people living with HIV participated, and their average age was 62 years. When we were sampling the participants, we only targeted people living with HIV above the age of 50 years. And the mean duration of them living with HIV was 11.3 years. The sample of nurses, which was a second data source, comprised of 9 nurses who had an average 6 years experience providing antiretroviral therapy services. From the integrated review of literature, 12 articles were selected from 2013 to 2023. These articles were from the UK, USA, Ghana, Tanzania, Saudi Arabia, Brazil, Canada, and Thailand. The majority of studies were from 2020, 4 of them, and 1 each study was from 2013, 2019, 2021, 2022, and 1 was from 2023. The findings from the older people, which was the first data set, revealed 2 main themes. The first one was healthy eating, and the second one was physical activity. Concerning healthy eating, we found that older people usually consumed a diet consisting mostly of indigenous whole grains, fruits, and vegetables. And these indigenous whole grains included crops such as sorghum, pumpkin leaves, and they also ate a lot of fruit and vegetables. And their choice, their preference for choosing this type of food was that they grew up in the rural areas. So there was an element of rurality which influenced the choice of food they liked. And their diet consisted mostly of carbohydrates. They would, from the study, we found that at least 50% of the diet was carbohydrates. And they would consume varying and lesser proportions of fruit and vegetables and protein. Their physical activity patterns, most of them were engaged in some form of physical activity, but the work that they did is the one that facilitates their physical activity. It could be work for economic purposes or work that they did within their homes, the domestic chores. Women were mostly engaged in domestic chores as a form of physical activity. And this physical activity included a lot of walking. They routinely engaged in walking, and some of them also engaged in routine physical activity, routine exercise, which was structured. One even say that I did sit-ups, I walk around my house, I did jogging. So those were the structured exercise regimes that some of them followed. And then we also found that older people living with HIV did not do a particular type of physical activity, but they engaged in various types of physical activity, such as walking, cycling, domestic chores. So those are their physical activity regimes were varied. And from the nurses' side, we found 2 main themes. The first theme was screening. When they screened all the people for type 2 diabetes who were living with HIV, they followed the same routine as they did with the general public. There was no specific intervention or screening measure for people living with HIV. So whether you are living with HIV or not living with HIV, the screening was similar. And then they would also do random blood glucose testing as part of their screening. And screening would include an assessment of signs and symptoms of type 2 diabetes. They would ask persons, do you have increased thirst? Do you frequently go to the bathroom? Or do you have a family history of type 2 diabetes? And this screening was supported by a multidisciplinary team. They would engage the medical doctors or the laboratory scientists in their screening. The second theme from the nurses was the health education. When they provided health educations, the nurses in Harare would inform the older adults and encourage them to perform physical activity, and then they'll also educate them on healthy eating. But concerning the issue of a health education on physical activity, it was mostly just encouragement. They would just say, don't sit around, you must be physically active. There was no specific parameter to say this is the amount of physical activity that you ought to be doing. It was just a general blanket to encourage someone to be physically active, but no amount of time or intensity of physical activity was explained. And then the health education to prevent type 2 diabetes was done in groups. But it wasn't only for type 2 diabetes. They would educate about all non-communicable diseases. They'll educate you about how to prevent hypertension, type 2 diabetes, and all other chronic illnesses in a group. But when they do notice that there's somebody who's particularly at risk of type 2 diabetes, for instance, those with a family history of type 2 diabetes, that's when they could engage in one-on-one health education to try and prevent type 2 diabetes. And then from the integrative review of literature, we found 12 articles that we integrated. And these, like I indicated, were from 2013 to 2021. Some of them included the guidelines, like the guidelines on art in Zimbabwe. And then we also included the WHO guideline on physical activity and sedentary life, which was first published in 2022. We also included a narrative, a systematic literature review, which was done in the UK. And the rest of them were actual studies that were done in Ghana, USA, Tanzania, Saudi Arabia, UK, Brazil, and Canada, and Thailand. And then the findings from the integrative review revealed three main themes. The first one was that screening should be HIV and AIDS, should include HIV and AIDS specific risks, and should be done from the earlier ages of 42.2 years. And screening should be done on a routine basis, and it should be done on initiation of they should conduct a confirmatory diabetes diagnostic test, and which should exclude the glycated hemoglobin test, mostly because the glycated hemoglobin test was underestimating the prevalence of type 2 diabetes in older people living with HIV. And when people who are living with HIV are screened for HIV, this screening should also include their self-care abilities, their ability to eat well, their ability to engage in physical activity. Health education should also promote the consumption of a healthy diet consisting mainly of fruit and vegetables, whilst 50% of the carbohydrate intake should be whole grains. And health education should promote specific parameters set by the WHO 2020 guidelines for physical activity and sedentary life. And then the pharmacological interventions is that metformin, which is an anti-diabetic, can be used when lifestyle interventions fail, especially in cases whereby you find there are older adults who cannot engage in physical activities, such as those who are disabled. And findings from the integrative literature review also supported the use of a multidisciplinary team. So in summation, the interventions to reduce type 2 diabetes amongst people who are living with HIV include screening people from a younger age, assessing HIV and AIDS-specific risks, diagnostic tests on AIDS initiation, which excludes the glycated hemoglobin tests, and this should be done routinely, at least annually. And health education should provide information on adequate physical activity parameters, which are recommended by the WHO 2020 guidelines. And also this should inform them on how to increasing consumption of fruit and vegetables. And lastly, metformin may be considered as a measure to reduce type 2 diabetes in older people where lifestyle interventions fail. In conclusion, Harare is in Zimbabwe, which is in Southern Africa, where there is a high prevalence of HIV and an increasing population of older people who develop chronic age-related non-communicable diseases like type 2 diabetes. The increase in urbanization in Zimbabwe has also increased type 2 diabetes, which will increase the disease burden in the region with a high HIV prevalence. As such, interventions for the reduction of type 2 diabetes amongst people living with HIV/AIDS mitigates the high disease burden from type 2 diabetes in a high HIV endemic area through focused screening, health education, and the use of pharmacologic interventions. Thank you very much.
My name is Jan Kestot. Thank you for the introduction. I'm a physician in Belgium, and my specialty is injecting low concentrations of glucose or dextrose into joints, into soft tissues, into fascia, into muscles, near tendons, and so on. The main topic of glucopuncture is pain management and tissue regeneration. But here, today, we will talk about the application of glucopuncture for Dupuytren. We know that Dupuytren is a condition which is difficult to treat. We know that the application of surgery or steroid injections is not very helpful. It's a rather new therapy. The name is only a few years old, and it's a new technique which tries to use a natural product without side effects instead of steroid injections. Most of your doctors worldwide have learned to apply injections with steroids to treat pain, inflammation, and musculoskeletal issues. And we have found out over the years that sugar water 5% injections like glucose 5%, which is mainly used in Europe, or dextrose 5%, which is mainly used in America and Asia, is a very good alternative. And in the next slide, you will see that we use the international abbreviations of glucose 5% and dextrose 5%. We do not add local anesthetics, although it's allowed. It's not required because 5% is not very painful. And we never add steroids because the steroids might even block the effect of the glucose injections. We have two types of glucopuncture. The first one is patient-guided glucopuncture, where we usually use multiple injections. And the diagnosis is based on observation of the patient, which means the patient tells you where they have the pain. You look for pain points or trigger points through using your hands. This is especially interesting for doctors who live in low-income areas who have no access to MRI, X-rays, or ultrasound. These injections are given by anatomical landmarks. The second one, which is becoming more popular these days, both in Asia, Europe, Africa, and the Americas, is screen-guided glucopuncture. There, the doctors usually use one single injection, and they do it while having the ultrasound application in the left hand and the syringe in the right hand. And by doing so, they can be very accurate and inject very close to a particular nerve, like, for example, a carpal tunnel syndrome. They inject right to the median nerve under guidance of ultrasound. And there are several RCTs, randomized controlled trials, proving that the effect of dextrose 5% is the same as steroid injections after 6 months, which I think is an amazing result because steroids have a lot of side effects, which we haven't found yet with the dextrose. So the first one, and that's the one I'm going to discuss today, is patient-guided glucopuncture. And these are what they sometimes call blind injections. Blind means that you don't need, that you don't use X-rays or ultrasound while giving the injections. And multiple injections are given each session, and it started already in 1977. For example, here you see a patient. This is a young sports athlete, a runner, and this case will be published this month in the European Journal of Medicine. And he shows you the pain region on the left slide. in both shins. And these pain points are very superficial. I can, with very light pressure with my thumb, I can identify the pain which the patient confirms to me. And then I will give, like, for example, 5 injections on each side with the glucose 5% or dextrose 5%. Here we will see intracutaneous injections. Intracutaneous injections are given, for example, for neuropathic pain, like post-herpetic pain. Like this lady, an 88-year-old lady with zona. She had horrible pains on the left side after zona. She received many treatments from the hospital, conventional painkillers, which made her dizzy and gave her memory loss. And after 5 or I think 6 sessions with intracutaneous injections, as you see here on the picture, she got rid of her pain completely. This article is published on PubMed. If you type my name, you will see a few articles, and this is one of them. Here is another example of someone receiving intracutaneous injections for neuropathic pain. For injection into the fascia, which is a very superficial layer just under the skin, we apply the so-called tangential injection approach, which means that we try to reach as much as superficial fascia as possible with our injections. If you inject in perpendicularly, that technique is applied when we want to give intramuscular injections, like, for example, in the same area in the trapezius muscle. On the next slide, we give an example of intraligamentous injections. In this case, this lady has pain in the left sacroiliac ligament. We inject glucose 5% in these areas. Sometimes 1 point, if you only find 1, sometimes 3 or 4 or 5 pain points in the ligaments. Here is a case of Dupuytren. This case is a patient who had for several months an induration of the palmar fascia. And we gave 2 injections in the area with glucose of 5%. And after a few sessions, we were both very happy and surprised at the same time to see that the lesion was getting weaker and weaker and weaker. So we are now talking about patient-guided glucopuncture. So the patient says on the left photograph, I have pain here on the lateral side of my left knee. Then my hand, examining hand, will look there for pain points in the fascia itself, or higher up trigger points in the lateral part of the quadriceps muscle. These are very common techniques applied to glucopuncture, where patients notice that after 2 or 3 sessions, it usually takes a few sessions if it's chronic, the pain disappears, sometimes even without injecting the pain zone itself. The latter is typical for trigger point injections, and those doctors here in the audience who are familiar with the Prevalence Simon's trigger point therapy, that they're 2 famous books, more than 20 years old, they are familiar with the technique, but they used procaine, and we use glucose 5%. For example, intramuscular injections are very common. The patient shows on the left photograph the pain region on the left lumbar area. X-ray and MRI were normal, but the pain was always there. Antiphlogistic medication and painkillers did not produce any results. So we injected, you can see it on the right side, with a 4-centimeter needle, it's about 1.5 inch, into the muscular tissue, several spots in the area. Here you can see an example of intramuscular injection in the trapezius area. We sometimes use pincer palpation with the left hand to lift up the trapezius muscle to prevent you from injecting too deep into the lung. This is, of course, very difficult to reach the lung like this, but out of safety measures, we sometimes apply this technique. Here you see a patient, this is also being published, who has pain in the midline between the shoulder blades. It's there for a long time. And he receives 5 injections in the pain points, in the ligaments, in that particular pain area. The second part of glucopuncture is screen-guided glucopuncture. This is typically applied in modern hospitals. It's, of course, safer and more accurate than blind injections. And for those doctors who are experience with ultrasound-guided injections or fluoroscopy-guided injections, but the latter are less common, you can consider to use sugar water injections instead of the steroid injections. We know that sugar water injections are much safer, but now we have the difficulty to convince conventional doctors in hospitals like orthopedic surgeons, neurosurgeons, and so forth, to convince that sugar water could even be effective. They also think, oh, sugar water, that's a placebo. We used to give sugar as a placebo in tablets to compare to conventional medication. So we have a long way to go to bring the minds of those doctors into trying sugar water injections instead of the steroids. Of course, there is an exception. When you're dealing with rheumatic arthritis, a very severe rheumatic arthritis, you give one shot of steroids into the joint, and maybe 1 or 2 days later, everything is gone. The swelling is gone and the redness is gone. This is impossible with sugar water injections. But on the other hand, I would say that sugar water injections seem to be better for long-term results and for inflammation, chronic inflammation, and also for neuropathic conditions. The next slide here, I will show you, because sometimes they say, okay, what you say is just a few patients. Do you have any RCTs, any control trials? Look at it, the first one, 2017, Mayo Clinic. It's a very good double-blind control trial. What did the guy do? He injected perineural dextrose for carpal tunnel and noticed 6-month efficacy, better than the steroids. In the next one, you see he compared with some other authors in 2018, a comparison of 5% dextrose versus steroid injection, triamcinolone injection for carpal tunnel syndrome. And there's a similar one for ulnar neuropathy. Remember this, for neuropathies, sugar water is amazing. The ATP it produces in the mitochondria is amazing for nerve inflammation. You have a few others. This is one of the for general peripheral nerve entrapment syndromes, and the other one is a first report in 2022 of hydrodissection, which means you inject a large volume of 5% dextrose around the nerve to bathe it into the sugar water and to release it also from the surrounding tissues. This can only be done, of course, with ultrasound. You know, a few others, 2023 we are now. Proximal nerve, median nerve hydrodissection. Then again, a comparison between 5% and dextrose for carpal tunnel syndrome. Then Professor Lam from Hong Kong, he also did a systematic review and meta-analysis published last year. There are 2 of this year. Volume effect of nerve hydrodissection. They found out the more you inject, the more volume, even the better the results. And the same for the last one I have here from the beginning of this year. Another nerve hydrodissection with dextrose 5% for carpal tunnel syndrome. I just mentioned these to show you how important this technique can become in the future. So we have some studies, but it's all very young. The first one who published about it is the Korean doctors Kim in 1997. I was already using therapeutic local anesthesia, a German or rather an Austrian technique, where we inject procaine or other local anesthetics, and we inject them into muscles, into joints, into trigger points of muscles and near tendons and so forth. And the Korean article in 1997 showed that this is the book from the therapeutic local anesthesia. It's only available in German. And here you have some examples of injecting to the joint, into bursa, the peripheral nerve around the shoulder, for example. Also on the right, on the bottom, you see the TLA trapezius, which means that we're injecting to trigger points of the trapezius muscles. And here you will see, for example, the TLA applied for tennis elbow, where they inject into the brachioradialis muscle. So all these techniques are very, very old. But then in 1997, which is more than 20 years, more than 25, this doctor, and I'm still grateful to him today, did a comparison between the effects of dextrose, saline, 0.9%, so as that was the placebo, and lidocaine as a local anesthetic for trigger point injections. And he found out that the sugar water 5%, the glucose or dextrose, is better than the local anesthetics. So that was for me like, oh, an opening and a sort of game changer, because I thought I can now use sugar water and have better effects than with the procaine or another local anesthetic. And this is the article, but it was only available in Korean. And nobody, of course, reads Korean outside of that country. But fortunately, there was an abstract that appeared in English, and that is how I found out. So we replaced the local anesthetics by glucose 5%. First, we started to test them, as in the article, for intramuscular injections. And as we noticed better results with compared to procaine, we started slowly to use more and more of the sugar water 5% for ligaments, joints, and the fascia. And later on, we also applied it into ligaments and also into joint. And these days, ultrasound was not used very common. It was almost nobody was using it except for diagnostic tools, not for injections yet. So we started to give these glucose or dextrose 5% injections since 1997. Here you see, for example, a patient, a sports athlete who had injured her left calf during tennis, and we inject her with a 4-centimeter 27G needle, which is quite a thin needle and very interesting for these injuries. And we saw almost immediate result after one session, and complete eradication of all pain and all functionality was recovered after 2 sessions. So even, especially in sports medicine, this is a very interesting technique because it's not on any doping list and it's very safe. So over the years, we developed new blind techniques, and we also tested shallow injections, like in the superficial muscles, in the epidermis, and the superficial fascia. So we could say the main ones are intramuscular, IM, are given for myofascial pain. IF stands for intrafascial, the superficial fascia, which is just under the skin, which are given typically for vague musculoskeletal pain. And IC injection, intracutaneous, the one you saw in the beginning, very superficial. These are given for neuropathic pain. And here you see some articles on glucopuncture. I only started to publish about it in 2021 because I was not sure if it was really working. So I also looked around a bit and contacted other doctors before I dared to share my cases. These are not clinical studies. These are all one or several cases in the publication. So the first in 2021 was the man we just saw with his dorsal back pain. And then the second one in 2022 was a glucopuncture for shoulder pain. The third one for tension headache, published in India. Then another one for intradermal injections for neuropathic pain. Then you see on the next slide for anterior knee pain. Then one with a doctor from South America about Achilles tendinopathy, with a doctor from Holland, one for traumatic periostitis for sports injuries. Then on the next slide, one for the postherpetic neuralgia. Then the one here for Dupuytren's disease, which is also the subject of today. We published our first one in November 2022. As you can see, this is all very young, this is all very new, and I'm receiving emails from doctors from all over the world wanting to learn this. And I can tell you, one of these weeks, we will have a free online course for everyone without any payment of the application of glucopuncture. The last one is with a doctor about lateral ankle pain for glucopuncture. And in the meantime, there are already a few more published, like this one here. This is last year, hamstring injury. Then frozen shoulder. Here we inject up to 10 cc of the volume to have more volume. Another one of a hamstring injury. Then with doctors from Asia about the injection for hip joint pain, and a few more. One of the history of glucopuncture that we have explained, also about perineural injection therapy, and the last one, the treatment of fascial pain with glucopuncture. So there's a lot going on, but we are still not, especially not in Europe, and I don't think in Asia and Europe and Americas either, we are not positioned yet in the, let's say, the official way of dealing with patients in sports injuries, in sports medicine, in neuropathic pain. All the doctors are still going back to the old regime. And I don't know why it takes so long, but we hope that in the coming years, more and more physicians worldwide are going to apply first sugar water injections instead of immediately, as we do here, my colleagues in Belgium go immediately for the steroid injections. Not just for the safety of the patient, because we know steroids are bad for your cartilage and your joint, can give tendon issues. You can have serious damage of tendon tissue if your needle comes too close. You can also have tissue damage of peripheral nerves when you inject the steroids. And we don't have these side effects with dextrose 5% injection. And of course, we know that because I've been teaching injection techniques worldwide for the last 20 years, and I noticed that in many countries, I've been to Asia, Africa, South America, in many countries, the doctors told me, your technique may be good, but for us and for our patients, this is very, very expensive. And we don't have ultrasound in every village. We don't have all these products available. And that is why we have started the international project called Sweet Solution for Medics. And here you find the website, and very soon you will also have access to the online course, will be completely for free. And here you see the hand and the syringe with the symbol of glucopuncture, because it's the hexagon form of glucose or dextrose. We want to give this to our colleagues so they can help their patients. And that is also the goal of my lecture today and of the future, let's say, publication that we will have, that we are going to forward this message that glucopuncture is an easy technique to apply in musculoskeletal medicine. You can inject it into joints, muscles, ligaments, into fascia in a very safe way. And we want to keep it easy to learn, safe to apply, so it can be done by a busy family physician or sports injury who has no access to ultrasound, fluoroscopy, or PRP and still have a lot of patients. And of course, if we are in doubt, we will, of course, take care of a conventional diagnosis, which may need MRIs or blood samples or whatever to exclude those pathologies which we cannot treat with glucopuncture. That's, of course, logical. Everybody understands. And the beautiful thing about glucopuncture, if you apply it without the ultrasound, is that you have a direct view on your patient. The patient shows you where you have the pain. You follow the pain. You inject there. You have him or her come back after a week or 2 or 3 weeks. You see how the patient reacts. You may have a temporary worsening because we are not putting the dust under the table. We are not, or under the carpet. We are not suppressing symptoms as you can do with painkillers or steroids. No, on the contrary, we will try and ask the body to repair itself, stimulate the immune system. And more doctors are now convinced that, in fact, glucopuncture is a technique to recharge the batteries of the cells, because we inject in the extracellular matrix, and there the glucose goes into the cell. There it will find its way to the mitochondria, which are the factories, the energy factories of our cells. And there, through the Krebs cycle, there will be an extra production of ATP, and especially nerves, but also other tissues have a high requirement, need a lot of ATP, need a lot of energy. And so by giving the local energy, you can support tissue regeneration, you can help the peripheral nerves to heal themselves, so the patient will have less pain. And in that sense, you can help patients in a safe and let's say easy way. For example, here the patient shows the pain region. It's going from the rhomboid muscles and also between the shoulder blade and the dorsal area, and you inject in these areas. Here, this patient shows she has pain on the right trapezius muscle. I push in those points, and I see these points are very superficial. So I need a short needle, I inject tangentially, and after a few sessions, my pain is gone. So this is a very pleasant way of working. Here, the patient shows with her left hand or finger where she has pain and on top, and I will inject there. It's as easy as that. These are the points that I inject. And sometimes we also inject OR, origin region. So she has pain in the neck shoulder blade, but we think maybe there is also a functional problem in the neck area. So we also inject in the neck area, although she does not have any pain there. All that is explained in the glucopuncture book. Same here, patient showing the pain region. Here you have pain in the back of the knee, and the pain is not very clear where it's coming from. So we start to look for the pain points with our thumb, and if we can find pain points, we will inject those. And by pushing deeper, you will have to inject deeper. If you already have pain with a superficial pressure, then you'll have to use a short needle and only inject in the fascia. It becomes very, very, very simple. Again, here, I think I've shown something similar earlier. Pain in the left area and injecting into the muscles on that same area. Another patient who receives multiple injections in one session in both pain points as well as in trigger points. Here the patient shows on the left knee on the lateral side where the pain is, and I look for pain points, and there's a trigger point a bit higher, and there I will give the injection. So we call this examination guided glucopuncture. And I think it's a wonderful tool for family doctors and sports doctors because it's based on clinical signs of the patient. You observe your patient, you examine the patient, and you inject. And it's as simple as that. And sometimes for some doctors, especially in my area, they look at me and sometimes they are surprised by the results, but they say to each other, how can this work if it's so simple? And also it looks so unprofessional because I am just following the patient and I'm not looking at the MRI or the ultrasound. And by the way, sometimes the MRI or the ultrasound can be misleading. I'm sure that one of you here listening to this has had a patient with pain in the right arm and the MRI of the neck is showing a hernia on the left side. And then the radiologist and the neurosurgeon are very annoyed because then it's like it's a false positive result on the one side and a false negative result on the left side. While we in glucopuncture, we look at the clinical signs and mainly, not always, but mainly are guided by what the patient says and what we find during the clinical examination. So we inject pain points and trigger points into muscles and into ligaments. And for those who are new into this, we recommend them to just give intercutaneous injections, which by the way are a bit more pain for the patient, I must warn you, and the intravascular injections for vague musculoskeletal pain. And vague pain means that the patient points out a larger region of pain than the one that corresponds with the radiological examination or with the anatomy. Sometimes they say my pain starts on my shoulder, goes to my left elbow, and then stops. Which is it? Is it the shoulder? Is it the elbow? Is it some muscle? This is what we call vague pain. And in many cases, we see that the fascia is extremely important. So here again, you show the patient shows where he has the pain, and you are going to be injecting in that area. I think this is quite simple and looks too simple to be true. Here again, the patient lays on and I ask him, where is your pain? And that is going to be the region where I inject. Here, the older lady with her knee has pain on the right knee on the frontal side. It's not a bursitis. There's no patella tendon pathology on the ultrasound. I inject in the fascia very superficially, and the pain after a few sessions was much better. And we didn't inject into the knee joint. So sometimes these easy injections can be surprisingly effective. For example, here a patient says, I have pain in these two areas. What's this? It's not a typical hip problem, but the hips were okay, x-rays and were all normal. And we look for pain points in that area. And what we will do is injecting those in that area. So to sum up a bit, I would say that glucopuncture is a very new technique. It's interesting for those doctors who are still using steroids and wondering, is there something which is better and safer for my patients? And I think there is. And I think in the coming years, when we'll have more clinical studies, more and more doctors will switch from one product to the other. And of course, they are much safer than the steroids. But when you want to learn about glucopuncture, soon you will have the course. There is already a book which was published in India last year, May last year. But then you learn about a new product, about new injection techniques, but easy ones. But you have to remember, you need, of course, more sessions than with steroids. Except for very fresh sports injuries, then 1 or 2 sessions can be enough. If you're having a patient who has low back pain for 3 months or 3 years, then of course you have to say you have to book at least 3 or 4 or 5 sessions. And to conclude here, I would say, what are the goals of the glucopuncture? The goal of glucopuncture is to modulate regional pain, support tissue repair, and to regulate vascular integrity. The latter is mainly for injections into the superficial vascular. So I already mentioned this briefly. For acute lesions, you only need 1 or 2, 3 sessions, and you can give it quite quickly. For example, a soccer player has had a muscle injury on the Sunday. They come and see you on Monday, on Thursday, and they will be fine. Otherwise, when they have chronic pains, like which is there for months or years, we usually start with once or a week or once every 2 weeks, and then we gradually go to once every 4 weeks. And the typical number of sessions is between 3 and 10. And as I mentioned before, you could have some worsening. It's not really worsening, but patients may have more pain the next day or even more stiffness, and then they might panic or conclude that something went wrong, while this is the beginning of the healing process that we started. And especially with chronic cases, the pain has been suppressed for weeks, months, or even years, this is always a possibility that you have to discuss with the patient and warn them beforehand. That's what I was just saying here, that we are not putting the symptoms under the carpet. It's like driving a car and there's a red light in the dashboard. Then you put something on top of it so you don't see the red light. No, we're not doing that. We're going to look, where is the red light coming from? What is the sign of it? And try to repair it so the red light will go out by itself without a painkiller. And that's again about the reaction phase that I told you about, which is also possible is that you see after 1 or 2 sessions a relocation of the pain, which means the patient has pain on the front side of the shoulder, and after 2 sessions, it goes to the bicep area. And this is typical because the fascia is adapting. And that is so beautiful about the fascia, that it connects not only all parts of the body. I have written an article just about the fascia, if you would be interested. And that may explain why sometimes the pain relocates. We call it the new pain region. And you can inject in your next session that new pain region. As I said before, we give multiple injections, and they are typically given with very small needles. 30G or 27G are the most commonly used. And here, I don't know how much time I still have left, but here are the target tissues that we use. Intercutaneous, intervascular, and intramuscular are the most popular ones, especially for the beginners. Later on, you can give injections around the tendon, into ligaments, especially for traumatic events, very important, into entheses, and of course, into joint cavities. This is, for example, a publication that we had, I think, about a year ago with Professor Lam from Hong Kong, where we treated patients with a pain in the thigh going down the leg, and we injected into a muscular trigger point in the left gluteus muscle. But here, you need a longer needle, between 6 and 8 centimeters, depending on the obesity of the patient. This is a bit more an advanced technique. You can have pain in the hip area, and the patient, it's very deep, but the X-rays or the MRI of the hip is normal. Where does it come from? A lot of those pains are coming from the muscles, the gluteus muscles, for example. You also have patients who say, I have a very superficial pain on the lateral side. But ultrasound doesn't show any trochanteric bursitis or anything else. It could be fascia lata, for example. It's a bit bigger fascia than the one that we inject elsewhere. And then you can give multiple injections. It's about, on average, 1 centimeter deep only. Very easy to give. You can do it in 10, 15 seconds. Here,
Hello,
this is a
Dr.
beautiful
Keshot.
example. Oh, do I have to stop?
Hello, Dr. Keshot. Can you
Yes.
please conclude so that we can give a chance to other presenters?
Of course. I forgot my time. I will stop in 1 minute. So referred pain, this is the last I'm going to show you. The pain is on the patella tendon, which is on the right side, my left hand. And on top of the patella, you see my other hand, my right hand, pushing with the thumb into the muscle, the quadriceps muscle. So the pain is at the patella, but I inject into the quadriceps muscle. This is called referred pain from a muscular trigger point. Okay, I'm going to end right here. I want to thank all of you for your attention. And okay, here we go. I have a few faces of the, but that is for some other occasion. And I want to thank the organization for letting me give you this lecture. Thank you.
Good evening, everybody. My name is Mohammed. I'm working as a research fellow at Stockport NHS Foundation Trust in the UK. And I'm going to present on advancements in the hepatocellular carcinoma, its diagnosis and treatment, and embracing non-invasive techniques and exploring liver transplantation. Can you see my slides here? Right. So hepatocellular carcinoma, as we all know, is the primary form of liver cancer that originates from the hepatocytes and represents around 90% of all liver cancers. It's the 5th most common cancer in men and 7th in women worldwide. And it's the 3rd leading cause of cancer-related deaths, surpassed only by the lung and stomach cancers. Incidence varies significantly, and it's highest in Asia and African countries. Importance of early diagnosis and treatment of cancer, hepatocellular cancer, cannot be overstated, of course. It offers the possibility of curative treatment such as liver transplantation, surgical resection, and ablation therapy. Diagnosing early stage cancer is difficult because of late cirrhosis diagnosis in most of the patients, and high-risk individuals should be part of surveillance program. That's why. There are certain risk factors, as most of the doctors worldwide know, that viral hepatitis, chronic, especially hepatitis B and C, cirrhosis, which comes from hepatitis mainly, and alcohol use. Men are more likely to develop HCC than women, and alcohol consumption is one of the other risk factor. Some aflatoxins, which are cancer-causing substances produced by certain types of mold, can increase the risk of HCC as well. And lastly, obesity and diabetes type 2 mainly are associated with high risk of developing HCC. If we talk about the pathogenesis, there are some genetic alterations, for example, changes in DNA, such as mutations and chromosomal abnormalities. They play an important role in the development of HCC. For example, homozygous deletions in the chromosome 9 and high-level DNA amplifications in chromosome 11q13 and 6p21 have been identified. Viral hepatitis, chronic infection, whether it's hepatitis B or C, can lead to cirrhosis and liver cancer. Cirrhosis, of course, caused by either hepatitis or any other form like alcohol or some other causes, can lead to HCC as the liver attempts to repair itself, leading to cellular changes that can become malignant in the end. There are some environmental factors and toxins, for example, aflatoxin B1, and it can cause DNA damage and contribute to development of HCC as well. There are current challenges in the diagnosis and management, of course, in the early detection, because most of the patients HCC often develops in patients with chronic liver diseases, which can mask symptoms until the disease is advanced. Early detection is crucial for effective treatment, but remains very difficult. It's of heterogeneous nature, which essentially means that it arises from various etiologies and demonstrates complex pathophysiology and morphology. The diagnostic methods at the moment, for example, in mostly countries, ultrasound abdomen is used and alpha-fetoprotein biomarker testing. They're not always reliable for detecting early stage cancer. Of course, in many countries, CT and MRI is used, but it's not really available in most of the countries very easily, and it's not really ordered in the initial stages anyways. So, but they can be, even CT and MRI can be limited by the size and location of the tumor, as well as the patient's underlying liver condition. The molecular biology of HCC is diverse, with many genetic and epigenetic alterations contributing to its pathogenesis. This diversity complicates the development of universal diagnostic markers. There is a need for more sensitive and specific biomarkers for HCC, as of many other cancers. Current biomarkers have limitations, both in sensitivity and specificity, and especially in the early stages of the diseases. Liquid biopsy, this promising technique could allow for non-invasive detection of HCC, but it requires further validation and standardization before it can be widely implemented. Translational developments, advances in next generation sequencing, artificial intelligence, molecular imaging, and liquid biopsy hold promise for improving diagnosis. However, these technologies need further research and development for a practical application. There are new guidelines in diagnosis of hepatocellular carcinoma. They emphasize the use of imaging techniques, specifically ultrasound, CT, and MRI scan. Staging-wise, the use of Barcelona Clinic liver cancer staging system to classify the severity of the disease and guide treatment options. In management, to provide guidance on various treatment options, including surgical resection, liver transplantation, and local and systemic therapies tailored to the stage of the disease. Treatment outlines based on the stage of the HCC, including surgery, local regional therapies, and systemic treatments. And also suggest regular follow-up with imaging and clinical assessment to monitor for recurrence of the disease, and so that they can be managed accordingly. There are currently non-invasive diagnostic modalities used. For example, MRI, which uses magnetic fields and radio waves to create detailed images. It doesn't use ionizing radiation and is considered superior for many patients. CT use X-rays with computer technology to create cross-sectional images of the body using high-dose radiation. There are certain biomarkers, for example, transcripts, DNA genes, proteins, and metabolites that indicate whether a biological activity is normal or abnormal. In the imaging advancements, there are certain advancements, including high-V MRI. It offers improved implant imaging so that it reduces the metal distortions, enhances diagnostic capabilities for imaging metal implants, reduce susceptibility challenges, and it provides pulmonary imaging opportunities because of its unique field strength. It uses reduced helium. The development of this has made it feasible to install smaller, lighter MRI systems in spaces where traditional larger technology wouldn't fit. This also contributes to sustainability efforts. So if you talk about the AI adoption in radiology, it's deployed across medical imaging, including CT scan, to augment staff capabilities, improve exam throughout, and enhance imaging quality. On the web-based enterprise imaging system, these systems are basically replacing traditional PACS, which is used in most of the system in the West, allowing clinicians to access imaging from anywhere in the world. Cloud-based storage is also being used. Enhanced images, also it uses contrast agents to produce clearer, more reliable images, often comparable to those obtained with CT and MRI scans. And they're safe, radiation-free, and present no known risk to kidney or liver damage. And it has wide applications as well. For example, in diagnosing heart diseases, characterizing tumors, and monitoring cancer therapies. There are certain biomarkers in HCC. We will all be familiar with alpha-fetoprotein because it has been a traditional biomarker for hepatocellular cancer diagnosis. The optimal threshold for AFP levels in diagnosing is debated, of course, but systematic review suggests that a threshold of 400 nanogram per milliliter may offer better sensitivity and specificity compared to lower thresholds. AFPL3 and DCP are variants of AFP and desgamma carboxyprothrombin, respectively, which have shown promise in improving diagnostic accuracy when used alongside traditional AFP measurements. Cell-free DNA has been identified as a potential tool for early detection of HCC. RNA sequencing data and machine learning, it's a novel transcript biomarker for HCC using RNA sequencing and machine learning. For example, transcripts such as PARP2 202 and SPON2 203 and SERVAN 211 have demonstrated high accuracy in differentiating healthy and HCC cell models. Next generation sequencing has had a transformative impact on the diagnosis of HCC, offering a more comprehensive understanding of the genetic landscape of the disease. It's more precise. It facilitates the identification of genetic alterations, and the predictive value for matching an advanced HCC patients to targeted immunotherapy, providing insights for personalized treatment. The prognostic models for next generation sequencing can be used to construct basically to construct prognostic models that predict overall survival and treatment benefits for all the HCC patients. AI has been used in many aspects of our life, is very revolutionizing in the field of medicine and HCC diagnosis as well. Because it provides diagnostic performance, particularly deep learning and neural networks have been shown to improve the diagnostic performance of HCC detection. And we can see this sensitivity and specificity at 84 and 92% respectively. It supplements clinicians. It can be used as a diagnostic supplement for clinicians by screening imaging and highlighting regions of interest, thus improving workflow and reducing the risk of human error, as this has already been started to be used in some systems, but of course we'll see this happening in the near future. AI can be integrated with imaging and biomarkers, and the AI provides objective and consistent analysis of imaging data, which can enhance the accuracy of diagnosis. Integration of AI with information systems enables comprehensive analysis of the patient data, including imaging and biomarkers, facilitating more informed and reliable diagnosing. And by reducing diagnostic variability and optimizing data analysis, AI assists healthcare professionals in managing the increasing workload and reallocating healthcare resources effectively. Liquid biopsy is a game changer in this and basically HCC because it's a non-invasive. It involves the analysis of biomarkers present in the body fluids, typically blood, to consider the tumors. It can identify circulating tumor cells and fragments of tumor in the bloodstream. The genetic information can guide healthcare providers in selecting the most effective treatments according to the patient's individual basis. It allows for real-time monitoring of the cancer progression and response to the treatment, and they are considered safe than biopsies. Let's talk about the role of the liver transplantation in HCC treatment. Indications for liver transplantation in HCC patients include early stage HCC, in which the cancer is surgically unresectable. According to Milan criteria, traditionally patients who meet the criteria involve single tumor less than 5 centimeter or up to 3 tumors each less than 3 centimeter. And expanded criteria includes basically they've started to use liver transplantation, including the use of biomarkers and liquid biopsy for better patient selection in the future. The outcomes and survival rates post-transplantation in the long term, studies have shown that the liver transplantation can offer excellent long-term survival rate. For example, a study reported a 5-year survival rate of 90% patients within the Milan criteria, and recurrence rate 10-year post-transplant vary depending on whether the disease was downstage to within the Milan criteria or not. For those downstage, the survival rate was 52% and recurrence rate was 20%. And for those always within the Milan criteria, the survival rate was around 60% and recurrence rate was 13%. With time, the transplantation criteria has been evolutionized as well. Milan criteria, established over 25 years ago, has been a benchmark for selecting HCC patients for liver transplantation. But beyond Milan, there is an ongoing debate and research to extend this criteria. For example, use of biological markers that indicate tumor aggressiveness. Living donor liver transplantation. There's a tendency to extend the Milan criteria to allow more patients to benefit from these transplantations. And there are new scoring systems which have been developed to refine patient selection for liver transplantation, aiming to achieve 5-year survival rates comparable to Milan criteria. Post-transplant surveillance is critical component for the care of the patients who have gone transplantation. Especially for who have been treated for HCC. Circulating tumor DNA is used to predict relapse across solid tumors, and imaging and biomarkers, for example, MRI, CT scans, along with AFP levels are standard in most of the systems, and recurrence rates are approximately 8 to 20% patients post-transplantation in HCC. Long-term management strategies, talking about this, immunosuppression management is to balance the risk of rejection with the potential for cancer recurrence is a delicate task. Health promotion post-transplant care includes promoting overall health, managing comorbidities, and ensuring adherence to recommended lifestyle changes. Long-term survival requires regular assessments to monitor LFTs, detect complications early, and so we can manage them accordingly. To summarize my talk, the landscape of HCC management is rapidly evolving with the significant strides in non-invasive diagnostic methods such as advanced MRI, CT, and CUS technologies. The traditional biomarker is being supplemented by new markers to improve diagnostic precision. Next generation sequencing is enabling personalized medicine approaches while AI is refining the accuracy of diagnosis and treatment. Liquid biopsy is a pivotal tool for detecting and monitoring cancers, and liver transplantation remains a cornerstone for curative treatment, of course, depending upon the criteria the patient's fit or not. Pre-transplant management, including bridging therapies and downstaging protocols, is critical for patient care while on the waiting list, while post-transplant surveillance ensures long-term health and monitoring for recurrence. Looking ahead, the potential for immunotherapy and surgical advancements promises to further revolutionize HCC treatment. These are some of the references that we've used to write our literature, and it's an abstract of that we wrote for the chronic kidney disease in urological cancer survivor patients, its prevalence, risk factors, and management strategies. I would like to thank my co-authors as well, who include Abu Bakr, Ruqayya, and Subhan. So As we all know that CKD is a common complication among urological cancer survivors, as of any other cancer survivor patients, because of nephrotoxic effects of cancer treatment and impact of malignancy on the renal functions. So we reviewed in the prevalence, risk factors, and management strategies for CKD in this population, specifically urological cancer. The global estimated prevalence of CKD is around 13.4%, and patients with end-stage kidney disease needing renal transplant therapy is estimated between 4.9 to 7 million. And CKD affects more than 10% of the UK population. If we talk about the prevalence of the cancers, of the urological cancer, we can see the prostate cancer is the most common cancer, and it gives a significant burden in the UK, where 1 in 8 men will be diagnosed during their lifetime. Bladder cancer, over 550,000 new cases globally each year, and renal cancer, over around 400,000 new cases annually. There are certain risk factors which cause the development of chronic kidney disease, especially the advanced age, which comes with many other factors, as we know, development of CKD, some non-reversible factors, including dehydration, ongoing advanced age, pre-existing renal impairment. Many patients have been prescribed nephrotoxic drugs during their lifetime, specifically talking about analgesia, antibiotics, PPI, and contrast medium, which can be given for some investigation purposes for the cancer or any other investigations. Specifically in the cancer patients, exposure to nephrotoxic chemotherapeutic agents, for example, cisplatin, can cause CKD in the longer run, which is usually non-reversible, and surgical interventions, which is usually sometimes required, specifically in renal cancers, for example, radical nephrectomy or cystectomy, which cause of course, removal of the kidney on one side sometimes, or partial nephrectomy, which loses the kidney function, and also with cystectomy or any other intervention, the development of high pressure because of high pressure of the removal of the bladder in the case of cystectomy. Long-term effects of cancer therapies, for example, chemotherapy and radiation, we all know that they have side effects, including CKD and AKI as well. There are a few mechanisms which have been found which to cause renal and urothelial effects causing CKD. For example, cystic change in the kidney, interstitial nephritis, which can lead to development of cancer as well, papillary necrosis, urothelial changes, and hemorrhagic cystitis, and acute tubular necrosis, which is, I think, one of the most common one, and infarction. If we talk about the management, in the diagnosis, of course, we have to be careful when treating such patients. Therefore, several measurements of the bloods, for example, the serum creatinine, estimated EGFR, and urine analysis for proteinuria should be essential for early detection of CKD. And one shouldn't hold investigations, specifically ultrasound, and in suspected patient CT with non-contrast or contrast, depending upon the underlying cause, we can go for them as well. Treatment of CKD, although it is non-reversible in most of the cases, caution should be taken at the earlier stages, specifically in the patients with cancers and advanced age. Therefore, we should optimize their blood pressure and reduce the exposure of nephrotoxic agents. Any medications should be reviewed, whether the patients are in the community or in the hospitals, and their medications should be routinely reviewed alongside with their lifestyle medications, lifestyle modifications, including smoking cessation and dietary changes. one should involve basically all the different teams for the best patient care, involving urologist, nephrologist, and oncologist, so that to develop tailored survivorship care plans for the patient. Thank you very much, guys. Thank you for listening to me. You have been very patient, and if you have any questions, please do ask. And with this, I will conclude my presentation.
So, good morning, everyone. I'm Dr. Cha Eun Kong, a doctor currently working in Milton Keynes University Hospital in the UK. And thank you all for attending today's conference and giving me an opportunity to present my research article on survival analysis of lung cancer patients in Brunei Darussalam. So starting off with the introduction, based on previous research, cancer deaths is currently the worst primary cause of death, and lung cancer remained as the leading cause of death for decades, with about 1.8 million deaths estimated in 2020, and was the second most commonly diagnosed cancer in 2020 worldwide. So this also explains the patterns in Brunei Darussalam, where cancer deaths exceeds deaths caused by cardiovascular diseases and diabetes mellitus. And lung cancer actually became the top killer of the population since 2009. So just giving a statistical number, in 2016, 353 deaths attributable to cancer accounted to about 21.6% of all deaths in Brunei, and lung cancer itself resulted in 19.3% of cancer mortality, and it represents the first leading cause of mortality in men and the second leading cause of mortality in women after breast cancer. So therefore, the aim of my study is to investigate the survival statistics of primary lung cancer in Brunei Darussalam, corresponding to factors including the stages of the cancer, periods of diagnosis, and other social demographic characteristics. So the information provides further insight on the factors associated with survival of lung cancer and would be useful in the planning and implementation of cancer control program to further improve lung cancer survival in the country. So moving on to materials and methods, starting off with the study design and a population. So this is a retrospective cohort study of primary lung cancers registered in a population-based cancer registry of 15-year period spanning from 2002 to 2016. So all the primary malignant lung cancer cases, including the citizen, permanent residents, and foreigners in the Brunei Darussalam Cancer Registry, who were diagnosed during the study period from year 2002 to 2016 are included. And to give a bit of background on our cancer registry, it routinely sources nationwide cancer listing from the pathology department, National Death Registry, and medical records from the health service. And this database contributed to multiple publications such as survival analysis of colorectal cancer, breast cancer, and childhood cancer, to name a few. So there's been a great contribution of this cancer registry in the healthcare research field in our country. So in total, there were 797 eligible patients in total, and they were all included without sampling. And in terms of data collection, the identified data from the cancer registry was first collected after approval from Ministry of Health, and it included age, genders, date of birth, date of death, date of diagnosis, as well as the SER stages, district of residence, and ethnicity. So few statistical tests were being performed in this study. Firstly, Kaplan-Meier's tests were performed to find out the 6 months, 1 year, 3 year, and 5 year overall survival rates, as well as the median survival time with confidence intervals. And we've also performed the log ranks test to compare the survival probabilities corresponding to the stages of cancer, year of diagnosis, and socio-economic characteristics. So all patients have been grouped into 3 categories determined by their SEER stages on the extent of malignancy using the localized, regional, and distal staging system. And lastly, we have also used the Bonferroni correction to counteract the multiple comparisons problem. And p-value of less than 0.05 is considered to be statistically different and significantly in terms of statistic. So moving on to the next slide, I've attached the table that shows the social demographic characteristic of the study sample, including the age, gender, district, race, and the diagnosis during the 5-year period. And as well as the SEER stages, as I've mentioned, that's been broken down into localized, regional, and distant system. So moving on to the result sessions, Figure 1 demonstrates the cumulative survival curve of primary lung cancer in this study period. So Kaplan-Meier test showed that the 6-month survival rate for lung cancer patients in Brunei Darussalam was 62.2%, and it decreases to 51% after 1 year, and then 38% after 3 years, and finally 34.7% of patients survive after 5 years being diagnosed with lung cancer. And the median survival time of lung cancer patients was 12.4 months. And then moving on to Figure 2, Figure 2 demonstrates a survival curve of patients with different periods of diagnosis. So from our analysis, patients diagnosed with lung cancer from 2002 to 2016 lived significantly longer than patients diagnosed from 2007 to 2011. And those diagnosed from 2012 to 2016, from those diagnosed with 2007 to 2011 also lived significantly longer than patients diagnosed 2012 to 2016. And moving on to Figure 3, it showed the survival curves of patients with different stages at diagnosis. Patients with localized disease had significantly longer survival time than patients with regional involvement and distant site involvement. And patients with regional involvement also live significantly longer than patients with distant site involvement. And this is the last slide of the results section. Figure 4 shows the survival curves of lung cancer patients in different age groups. So comparison of the survival time was being carried out by dividing into 3 age groups, 20 to 39, 40 to 49, and 50 and above. And our analysis shows that the survival time of patients aged 50 and above at diagnosis had lived significantly shorter than those diagnosed with lung cancer at the age of 40 to 49. So just moving on to the discussion part. Firstly, we have found that the median survival time of lung cancer patients diagnosed from 2002 to 2016 was 12.4 months. And this number has actually doubled in comparison to 6.1 months in previous study, which investigated on survival analysis of those patients diagnosed from 1987 to 2012. And this likely indicates overall advancement of the healthcare in lung cancer. And throughout the past 20 years, Ministry of Health has increased the taxes on cigarette by almost 200%, which led to all cigarette retailers in Brunei actually cease to operate. And the Ministry of Health has also established the smoking cessation service in the community clinics. And previously, Brunei local hospitals only provided conventional surgical and chemotherapy. And therefore, patients with lung cancer who required radiotherapy are usually sent over to overseas, such as Malaysia and Singapore. So in order to provide treatment for patients closer to home, Ministry of Health has established the Brunei Cancer Center in 2009 for more advanced local treatment modalities. However, our analysis shows that the lung cancer diagnosed in the earlier years actually had the longer survival time than those diagnosed at the latest years, despite, as I mentioned just now, the recent introduction of local advanced treatments and implementation for strict tobacco control. And that difference could be contributed due to the refinement of the national cancer surveillance and reporting system over the decade. And since in 2013, there's been this introduction of electronic medical records. So in addition to those findings, we found that more than half, which is 57.5% of the patients, was only diagnosed when lung cancer had metastasized to other distant sites such as bone and brain. And the survival analysis also showed that the patients diagnosed with more advanced and metastatic stage of lung cancer have significantly shorter survival time than those diagnosed with earlier stage of cancer. A previous study was being conducted on the survival of non-small lung cancer patients in Brunei Darussalam, and they've observed that the 5-year survival rates for advanced stage were very low in comparison to other foreign reports, as over 41% of the patients had refused treatment offered by their medical professional, and they possibly opted in traditional medicine such as herbal remedies. And therefore, cultural background could also play a role on the poor survival in patients with more advanced disease. In the effort to improve the survival prognosis of lung cancer patients, patients with heavy smoking history or presentation of symptoms should undergo recommended screening tests to allow for earlier identification and treatment of malignancy. So there were a few limitations identified in this study. Firstly, the incomplete cancer surveillance system during the earlier study period might potentially lead to underestimation of lung cancer death cases, and therefore overestimation of the overall survival time of lung cancer patients in the earlier periods. Other than that, there were also missing details in the study sample, which were the stages of cancer at diagnosis in 75 patients and the living district of 37 patients in terms of the social demographic details. And this could potentially lead to bias in the overall survival analysis. And our study did not particularly include treatment modalities and risk factors such as smoking status of patients. So further research are recommended to investigate into the impacts of these factors and survival analysis of lung cancer patients, and it will better aid in the planning of cancer control implementation of the country. So I'm coming to the end of my presentation with just a notion that this study was carried out after gaining ethical approval from Institute of Health Science, University Brunei Darussalam, and the Medical and Health Research Committee and Ministry of Health as well. And that concludes my presentation. Thank you very much.
Good evening in Thailand and good morning for the people in Peru who's listening to me. And it's a pleasure and honor to be with you here in the science conference where holistic knowledge blooms, and the second International Conference on Global Healthcare 2024 in Bangkok, Thailand. My name is Gina Leo Montiveros. I am a PhD degree student major in public health from Lima, Peru. And the title of my paper is The Knowledge Prevention Measures Against Sexually Transmitted Infections in Peruvian Andean Adolescents. I'm gonna put this. This is the objective of the paper that we published before a few years ago. And below here, you have the reference in Vancouver. And we did this investigation was made with a teamwork. And I would like to give a special thanks to Juana Salas and Daniel Blanco for their commitment with this research. Today I'm gonna talk about the introduction, the methods, the results, and the conclusion. About the introduction, I want to remark two important concepts. in order to understand this investigation. The adolescence is a stage of life from 10 to 19 years old, and it is a vulnerable period during which adolescents may engage in sexual practice without adequate information and communication in the family environment, coupled with beliefs in myth taboos that trigger the search and curiosity for new experiences. Psychologically, the cervical lining in adolescents and young women makes them more vulnerable to STI. And the second one is the access to information and health services and context. There are problems in obtaining the necessary supplies they needed to avoid STI, and also barriers to accessing STI prevention services because they do not know where to find them, do not have adequate transportation, cannot afford to pay for the services, or do not feel comfortable in the places where they can access them. In Peru, the prevalence of STIs is estimated between 30 to 45% of the population. About the methodology, in the method, we use a quantitative, descriptive, and a cross-sectional study. In the sample, 150 adolescents from state high school from the districts of El Tambo and Chilca from Huancayo, Peru, who were selected through an intentional non-probabilistic consecutive sampling was used. In the ethical aspect, the research project was approved by the Research Ethics Committee of the Universidad Peruana del Centro. The validation of data collection instrument. In order to validate the data collection instrument, a pilot study was carried out to validate it. And the results, we applied the validated instrument to the target center. I want to talk about the study highlights. The first one is about the questionnaire validation. An original questionnaire was developed for this specific sample and went through the necessary processes to be applied. The second one is about the sample. The nature of the sample of the vulnerable population of the Andes in Peru. The first one about the questionnaire validation has not been done before, and the sample, there's no data about it. In this slide, I want to show you the sequence of the validation of the instrument by the expert judgment. First, we did the elaboration of the data collection instrument. Then, the elaboration of the consistency matrix and expert's card. Next, the selection of the sample, the adolescents, for the application of the questionnaire. Then, the validation of the instrument by the expert judgment. Next, the application of the instrument to the previously selected sample, then the statistical analysis, and the determination of the Cronbach's alpha coefficient. And finally, the determination of the Aikens B coefficient using the Losch Context Validity Index. I want to remark here that the instrument was found to be reliable for use with these adolescents, with a Cronbach's alpha coefficient of 0.794 and an Aikens V coefficient result of expert judgment of 0.697. This is the questionnaire in the original language, in Spanish. It's a part of it. About the description of the questionnaire items. First, I want to show you the topic of the knowledge. We did multiple choices questions related to the concepts, types, form of contagion, and method of protections against STI. And the second, the rate and value STI. And the second, the rate and value of each question. Each correct answer was worth 1 point, and incorrect answers were worth 0. About the distributions of questionnaire items, the first 13 questions assessed the adolescents' knowledge of STI. And the questions 14 to 18 assess knowledge of preventive measures avoid STI. And the consideration of STI knowledge level, we use the Stanine scale. We based on the formula plus minus 0.75 times the standard deviation. From this, we obtain the A and the B plots, which are the borders dividing the distribution in 3 areas. And the result was the low from 1 to 7, the medium from 8 to 11, and the high from 12 to 13. Now we're going to talk about the results, the descriptive tables, and the association measures. In the table 1, knowledge and preventive measures of Peruvian Andean adolescents regarding STIs, we have a descriptive table. This is all the answers that the sample answered. And I painted for you with green the remarkable correct answers, and I painted for you with red the remarkable wrong answers. And I want to resume for you. The Peruvian Andean adolescents know about the theory, even the gender, but they didn't know about the practice. For example, they know about the definition of STI, the AIDS. They know the causative agent of the syphilis, of the AIDS, even of the agent of STIs, etc. But they didn't know about the definition of sexual abstinence, or didn't know the proper use of the condom, of the sequence of the condom. Of the 200 Peruvian Andean adolescents included in this study, 53% were female and 47% were male, with a mean age of around 15 years old. Regarding knowledge of STIs, only 18% had a correct answer on the concept of STIs, while 8% answered incorrectly on the topic. In addition, both men and women had more than 70% incorrect answers. In the table 2, name association between knowledge about STIs and preventive measures used by Peruvian and Andean adolescents, we're going to talk about a statistically significant p-value. In this study, we found significant association between main mode of transmission of STI and 3 main modes of HIV transmission with the preventive measures to avoid contracting STIs. Also, we found significant association between definition AIDS with the main modes of transmission of STIs with the definition of sexual abstinence. Besides, we found significant association between the main modes of transmission of STIs with the safer sex practices to avoid STIs, and the condom to avoid the STIs too, in this part. However, I didn't find association between the adolescents that identified sexual relation as a principal practice to contracting STIs with the proper use of condom to prevent STI. But the adolescents that know the definition of STI we found it significant association with the proper use of condoms to prevent the STI. In the table 3, name level of knowledge of STIs by gender among Peruvian and Andean adolescents, we're going to see a descriptive table 2. In the under-leveraged knowledge level knowledge, we are going to see around 20%, even the gender. In the medium level knowledge, we are going to see around 75 or 76%, even the gender. And in the high level knowledge, we're going to see just 3% of this knowledge, even the gender. And this is a finding that we were worried about. In the discussion, in the consideration of the Peruvian adolescents population, the different biological, psychological, and social changes that occur during adolescence make it one of the most vulnerable stages of the human being. It is estimated that the adolescents population in Peru corresponds to 19.3% of the total population. Also, most Peruvian adolescents begin their sexual activity at about 14 years of age, which expose them to risk practices of contracting STIs. Since they do not have the adequate knowledge about these diseases or preventive measures. Finally, an important characteristic of this research is that the adolescents are of Andean origin and live in a specific culture. Some research has found negative attitudes among indigenous people regarding the use of physical protection, faithful and monogamous sexual relationships. In this slide, I want to show you that there is data that confirm the results we found in this study. This study were made in Latin America too, as you can see. In contrast to Tapia and Tapia's study in the population of Peruvian Andean adolescents, it was observed that only between 40 to 68% were aware of the laboratory tests for HIV diagnosis. Positive tests necessary for the confirmation of the diagnosis and diagnostic tests for STIs. This could be to the difficulty they have in accessing reproductive health services in the different health facilities and to the fact that the language used in these facilities is often unfriendly. In this chart, you can see that exist similar studies about prevention of STIs, like, for example, Cuba, Guyana, Peru, and Ecuador. And those have similar results with the present study, as you can see. About the conclusions. My conclusions are made about these 6 facts. Fact 1, condoms are known to exist, but neither formal nor temporary partner use them. Fact 2, it is not clear about the correct use of condoms, and also they are not familiar with the concept of sexual abstinence. In the fact 3, it is known that in Peru, the information provided to adolescents about sexuality, and especially about STI is still incipient, despite the efforts of health personnel and teachers, because it is still considered a taboo topic. In the fact 4, even more so in an indigenous population is more conservative, with macho tendencies, and where there are myths, stereotypes, and misinformation about condom use and preventive measures that put adolescents in risk of contracting STIs. Fact 5. Parents play the role of the first school for sexual education. Secondly, health professionals get involved with this population and their geographical location in the interior of the country, where information is not as massive as in the big cities. And finally, the fact 6. Another prevention front could be the teachers, who spend more time with adolescents in the classroom. They could clarify doubts on the subject, schedule trainings, lectures and forums on sexual education, organized and prepared by trained professionals who are liked and trusted by the adolescents. But I want to say here that in many times, the parents influence in the teachers, or the parents have influence in the teachers. In this slide, I want to show you the paper in the original language, that is in Spanish too. And finally, I want to present you the city of Huancayo, Peru. This is a picture of the main plaza or the square, the main square from Huancayo. It is located in the south center from Peru, known by the higher altitude because we are about 3,259 meters over the sea. If you want to visit, you came, you're gonna be very welcome, but you have to be prepared for the altitude high disease. We call soroche in Spanish. And I want to tell you something more. This research is really special for me because I was born there. And one of my dreams as a researcher was made investigation about my people. Thank you so much for letting my dream came true. Like I said, it was a pleasure and an honor to be here with you today. Thank you so much for listening to me. Muchas gracias.
Introduce myself. My name is Gurpreet Singh. I am currently the Vice President, Managing Director for Integrated Safety at IQVIA. I'm based out of UK. I've been in the drug development industry for about 20 years. And I've worked in various areas of drug development, right from data management to biostatistics, medical writing to pharmacovigilance, regulatory affairs. And today I'm going to talk about what's happening in the drug development industry, how the industry is progressing, and what are the various trends and challenges and opportunities that we see in this industry. Since I've worked with companies like CROs, IT-enabled companies, and pharma, most of my presentation discussion is going to be my experiences around working in these different corporate environments. If I could move to the next slide, please. So I'm sure many of you are aware that developing a drug and getting it to the market, right from preclinical research to marketing, it takes about 12 to 18 years. And over the last 10, 15 years, it's been fairly consistent that getting a new product to the market always takes about 12 to 18 years. And many a times the cost is over $1 billion. Now, with this kind of a setup that it requires so much of time and investment, the companies are making sure that there is a lot of investment that's happening in this space. Some of the top pharmaceutical companies who are having a significant portion of their annual revenues into R&D, and who will continue to do that. If you look at it from a statistics perspective, in 2026, we are expecting that Roche, Johnson & Johnson, Merck, Pfizer, and Novartis will continue to be the top 5 in terms of investing into drug development. And some of these are actually investing almost about 15% of their annual revenue into drug development. The idea being, to come up with newer molecules for the treatment of diseases for which either no medications exist or where there's a need for a superior medication. So that pursuit of, coming up with newer molecules is still there. If you look at the global clinical research market, this is currently estimated to be around $76.6 billion as of end of last year. And by the end of this decade, we expect it to be somewhere around $130 billion. So it's growing at about 10% annually, which is a very good positive sign for an industry, which indicates that, the pharma environment is good, is stable, and there is a lot of focus on R&D and drug development, which is then supported actively by the clinical research market. Now, if you look at from the key players in the contract research organization, so obviously these are the top 4 or 5 CROs who are working a lot with the pharma companies. And I'm sure all of you know that a pharma company cannot get a drug to the molecule alone, a market alone. They need an ecosystem. They need support from various service providers, which include clinical research organizations, IT-enabled organizations, and also in some cases niche service providers. So if you look at the overall ecosystem, while the pharma company is the owner or the sponsor of the drug, there's a lot of effort that the clinical research organization and IT-enabled organizations play. So if you look at the key players, IQVIA, LabCorp, Parexel, Icon, and Syneos Health are pretty much the companies which are doing a large portion of the clinical trials globally. And to support this ecosystem, the IT service providers are playing an important role, which includes companies like Accenture, Tata Consultancy, Cognizant, Wipro, HCL. These are the companies which are helping with the technologies to be able to expedite drug development, bring it to the market faster, at a lower cost, bring in the efficiencies, and also support on from a services perspective, because many of these drug development services can be expensive. And by these IT companies having to do this from locations which have higher expertise and lower cost is helping to also get drugs faster to the market. In addition to this, there are a lot of niche service players, who support global drug development, and these are players who support in areas like regulatory affairs or in literature vigilance or in, for example, medical affairs. Somebody who's specializing in pharmacovigilance. So a lot of these niche service providers are a part of this ecosystem, which is essentially responsible to get drug development faster to the market, and also bring in that efficiency to be able to reduce the cost. Next slide, please. So I'm sure all of you are aware of what clinical research is. Clinical research, essentially, as you would know, is a branch of healthcare science that determines the safety and effectiveness. So there are two important elements, safety and efficacy. And this will be covering all of the elements, whether it's medications, devices, diagnostic products, or even for that matter, any of the treatment regimens. So this is all the inclusive areas where clinical research is required. Now, if you look at it, these may be used for prevention, treatment, diagnosis, or for relieving of symptoms. It's not just about treatment, but also about how clinical research can help prevent and diagnose diseases. Now, if you look at it, clinical research and clinical practice may get confusing. In clinical practice, typically, the treatments are used where you have established treatments, while in clinical research, the evidence is collected so that you can have an established treatment which can be used for the clinical practice. So that's really the key difference, where people may be thinking, what's the difference between clinical research and clinical practice? And clinical research is often conducted at academic medical centers or research study sites, depending upon what's the nature of the clinical research that's required. These centers and sites provide the academic institution the access, and these are either done in larger metropolitan areas or smaller areas. But then these medical centers have their own internal institutional review board that oversees the ethical conduct of medical research. And I'm sure you know that there is a need for ethical ways of doing clinical research. So the institutional review boards play a very important aspect to that. The ecosystem, as I mentioned, it involves a complex network of sites, pharmaceutical companies, academic research institutions, clinical research organizations, IT-enabled companies, and the growing field of technologies are helping to make and manage the data and the factors of clinical research in an effective way. The clinical research management is aided by clinical systems. It could be different systems for clinical data management, for pharmacovigilance, for regulatory affairs, and all of these are well supported by the various IT companies. Next slide, please. I will not go too much into the phases of clinical trials. I think this is something which most of you would be aware. I mean, it's preclinical, phase 0, phase 1, phase 2, phase 3, and phase 4, which is the post-marketing. But in all of these, phases, if you see, the most important aspect is that we have to keep in mind the safety and efficacy of the drug. At the end of the day, what we do is for the benefit of the patient. and we want to make sure that these medicines, before they come to the market, they are tested, whether it's in preclinical or in the clinical phase, and we are able to establish the safety of this along with the adequate efficacy that's required, looking at the benefit risk ratio and getting these to the market. Next slide, please. So the global drug development functions are essentially comprised of 6 major categories. I mean, there could be more depending upon pharma organizations, how they want to set it up. But in general, if you look at it, these are the 6 key functions. The first one being clinical trial management, which is responsible to manage global trials, ensure that these trials are looked at end to end, the research data, everything is available. So that's really the clinical trial management part of it. Then there is the element of data management, wherein it's important to look at the data, assess them, analyze it, and ensure that this data is submitted to the health authorities for required approval. So there's a lot of element in terms of data analytics and data management that global drug development requires. The third element is biostatistics, which essentially is a combination of statistics and biology to be able to understand what are the various trends that you see with the molecule, what are the various aspects that you need to look at from the overall efficacy of the drug. So biostatistics plays an important role, not only from an efficacy, but also from a safety perspective to see what are the kind of signals that we are getting from the overall drug that we see. Then there is an element of medical writing where we are required to put in a lot of reports in place, whether it's the PEBRAs, whether it's the aggregate reports, the annual reports, which are required to be submitted to the health authorities. Pharmacovigilance essentially is the detection, assessment, understanding, and prevention of adverse drug reactions, adverse events. And this is a very important department of late, which is playing an important element as far as safety is concerned. And over the last 15, 20 years, pharmacovigilance has gained a lot of importance. I'm sure many of you would really recollect the Vioxx incident that happened in early 2000s, where the product Vioxx, which was initially prescribed for arthritis and for other pain-related diseases, when it was launched, it became a blockbuster. It became one of the highest-selling drugs. But then over a period of time, they realized that there were a lot of side effects associated with this, including myocardial infarction, and a significant number of patient population which use this succumbed to it. So the company which was actually responsible for marketing Vioxx had to pay several billions of dollars in lawsuits, realizing that if there was appropriate pharmacovigilance, this could have been prevented. So from then on, I think pharmacovigilance has gained a lot of importance. This area is where the pharma companies are making sure that they have the right teams, the right people to be able to have an effective pharmacovigilance system. And also, this is an area where health authorities or inspectors are extremely focused to make sure that the companies are having good pharmacovigilance practice. The next one is regulatory affairs. Essentially, as the name suggests, the department is responsible to interact with the regulatory bodies, the health authorities, ensure that all of the communication happens with them, ensure that the drug approvals are sent to them, and wherever the approvals are available, they are marketed, and any aspects with the products are informed to the health authority on time. So that's really how these 6 departments, and all of these 6 departments work very closely with each other. So if, for example, if you have to get a product to the market, that product will require a good collaboration, coordination of all of these 6 departments, plus a few more, to make sure that the drug is brought to the market in an effective way. Next slide, please. The 4 key elements of drug development, in my view, are essentially the people, process, technology, and partnerships. People are absolutely at the center because this is where the real expertise is. This is an area which requires a lot of knowledge, expertise, skills, and therefore you need to have the right people. They have to be trained, they have to be retained, so that they could deliver on the requirements. Then there is an element of process, and of late, the processes are gaining a lot of importance. There is a lot of element in terms of making sure that the processes are adhering to the quality and compliance standards of the health authorities, making sure that there are no gaps in the overall quality compliance of the process, whether it's the standard operating procedures or the various working procedures. But at the same time, there's a lot of focus now on the process excellence initiative, looking at how these processes can be more effective. Processes which have been there for a while are being relooked at with the understanding to make it more meaningful with the current trend. And that brings in the third element, which is technology. With technology coming in, with a lot of digital transformation happening, data analytics required, there is a need for you to also relook at your processes and see how those processes are designed to be the process of the future. So technology has brought in a lot of change. I mean, when I started my career in PV 20 years back, at that point of time, we used to get paper cases, adverse event reports. Today, none of that is on paper. Everything is technologically driven. We have systems which are automated. We have used robotic process automation. There is an increasing amount of use as far as natural language processing, artificial intelligence, machine learning. All of those elements are really helping us to make technology much more robust and helping global drug development in an effective way. Then the fourth element is really about partnership. Like I said, not every pharma company can get a molecule to the market alone. They need to have the right partnerships. They need to work with clinical research organizations, with IT-enabled organizations, and that ecosystem has to work together to be able to get that drug to the market. So a combination of people, process, technology, and the right partnerships is actually the key element as far as global drug development is concerned and getting the products faster to the market at a cost-effective way. Next slide, please. So as I said, if you look at on the top side, we're talking about people, the organization culture. It is very important to have the right culture, which ensures that there is no impact in terms of how the people are working. There's an innovative environment. People are getting the right support, the right collaborative approach. So companies are investing significantly on their organization culture and making sure that there is an innovation element that is brought in. Talent management is playing an important role, hiring the right talent, developing it and retaining it, because this is a niche area, this is a specialized area. People are required to be skilled, and therefore retaining that talent is very important. Then there is the third element of ensuring that there is a quality and compliance in what work we do. There's a process excellence element of it, and then, like I said, technology being what it is supporting. The transformation element and the data analytics are playing an important role. One of the other things which is happening very commonly in the pharma industry is mergers and acquisitions. Now, of late, you would have heard about a lot of companies acquiring bigger companies, smaller companies which have niche molecules. That trend is going to continue. This trend is going to continue. People are investing in newer molecules. Bigger companies, in order to have the right pipeline, they are investing in smaller companies, acquiring them, merging them. There is an example of companies merging. There are examples of company demerging. All of this means a lot of activities in the drug development space, a lot of requirements as far as people, process, and technology is concerned. At the same time, it's also making sure that the companies are investing in what's the right thing for the global drug development industry. So that's an important element. And then there is the budget element. All of this is driven essentially by cost and patient safety, ensuring that there are right products for the market. The patient is the one who needs to benefit. So the budget plays a very important and crucial role to have it in the market at the right time within the required budget. Next slide, please. So I'll quickly cover the few trends that we are observing. We are observing that there is a lot of trend in terms of personalized medicine. There is a focus of having a customized approach to drug development so that medications and dosing can be more finely adapted to the patient's genome, environment, and prognosis. Many of these include areas like development of trastuzumab for the treatment of HER2 positive patients. So this is an important trend which is picking up. How can we ensure personalized medicine? The second aspect is, and I'm sure some of you are aware, as far as the orphan drugs are concerned, there is a lot of focus on orphan drugs. even though these may not make a lot of commercial value, there's a need for companies to address the requirement of orphan drugs for rare diseases. And based on the 1983 Orphan Drugs Act, it is important for companies in the US and other places to look at how they could support this. There are incentives that they get from the government. There are companies which are specifically working on the rare diseases and coming up with, orphan drugs so that, these diseases can be treated. Next slide, please. The next two trends, if you see, are in terms of the newer models of clinical trials. And as far as the COVID is concerned, what COVID taught us is, we could look at how the decentralized clinical trials are required for the future. How is it possible for us to do this data collection or reduce the number of site visits that the patients or the clinical trial patients are required to do? So there's a long amount of emphasis on how decentralized clinical trials can be the way forward. Companies are investing in this direction and trying to make this a reality. Also, this ensures that there is lower barriers to participation, which results in greater patient interest and retention. At the same time, it gives the researchers an access to a larger population pool, which allows them to have a more diverse set of data when they are looking at the clinical trial aspect. So decentralized clinical models, clinical trials is a trend, and it's going to continue. The growing use of contract research organization, obviously, like I said, the pharma companies cannot do it independently. They need to have these clinical research organizations which are specialized, which have the ability to support the pharma companies in a better way and get these products to the market in an effective way. Next slide, please. The two other trends that you're seeing here is mRNA vaccine development. I think we all know that from the pandemic, there was a need to come up with COVID vaccines at a really short notice. mRNA vaccines played an important role there, but mRNA research continues on that. We are looking at how there could be vaccines to treat viruses, and even for that matter, diseases like cancer, if mRNA vaccines could then be the future of vaccine development. A lot of effort is now being put on biosimilars, and as you know, biologics are the ones which are extremely expensive. There is a need for us to find more effective ways of healthcare, which is affordable to people globally. And therefore, if we can have the right biosimilars in place, we could actually bring in that effective healthcare cost. So many companies have invested in this. This has also resulted in saving the healthcare system several dollars. As you see, the US healthcare system has already saved about $10 billion by the adoption of biosimilars. So companies want to continue to invest in this space and look at how we could have the right biosimilars or the similar molecules as far as biologics are concerned, which will then ensure that the patient healthcare can be made more effective. Next slide, please. Mergers and acquisitions, I already mentioned that trend is progressing. Companies continue to invest in newer molecules, newer companies. There is a lot of merger acquisition happening. There's demergers happening so that companies can work on their strengths and drive the business in the right direction. And there's also a trend of venture capitals investing in this industry, because these venture capitals have significant investment interest in the pharma space, especially because global drug development continues to grow at a phenomenal rate. So a very positive time as far as the merger acquisition and the investment trend is there. Artificial intelligence is continuing to play an important role. It has picked up significantly over the last few years. The healthcare artificial intelligence market is estimated to grow at about 5%, and it is growing at a CAGR of 62.2%, which means that this trend is helping companies to use technology to help make healthcare more affordable and more effective. And these trends indicate that there is ample room for integration of smart devices, smart diagnostics, and wearable technologies. Whether it's artificial intelligence, big data, or high performance computing, all of these are helping to accelerate drug discovery, and industry is also focusing on novel ways to enhance the medication properties such as assay development, 3D cell culture, and even synthetic biology. Next slide, please. There is a lot of focus on combination therapies. I'm sure, if you look at in terms of how the medications are prescribed, polypharmacy is a very common thing. People are using medications, are required to use medications because of multiple indications, multiple disease areas. And therefore, there is a need for us to relook at how the polypharmacy could impact, especially from a safety perspective. Multiple medications being used can impact patient, and therefore there is a lot of research happening in terms of combination therapies. What are the novel ways of these combination therapies? How these combination therapies can enhance the outcomes and also at the same time reduce not only the drug resistance but also reduce the adverse events. So the three elements of combination therapy is what is being researched to be able to make it more effective. The last trend, or there are more, but the top 10 is what I'm trying to cover. And if you look at the next one is drug repurposing. When you look at repurposing, the existing drugs for new indication is a very important phenomena. I'm sure you're aware of minoxidil, which was initially meant for something different, but then later on it became one of the wonder drugs for hair growth. So similar to that, there is a lot of research happening in looking at what the current medications could be repurposed for, and if they can be utilized into indications for which we do not have a very effective treatment at this point of time. So this is continuing as a trend, and this will continue because this is required for us to make sure that we are able to get drugs faster to the market, and also at the same time address diseases for which we currently do not have the right products. Next slide, please. That was pretty much my last slide. I really want to thank you all for...
Hola, mi nombre es Rodrigo Vázquez de Carso, yo soy pediatra e infectólogo, profesor asociado de la Facultad de Medicina de la Universidad de Chile y actualmente director del Departamento de Pediatría y Cirugía Infantil. Para mí es muy grato estar con ustedes y agradezco la oportunidad de poder participar en el segundo Congreso Mundial de Salud Global. Hubiera querido estar en forma presencial, pero la verdad que Chile queda muy, muy lejos. El tema al que me voy a referir, y agradezco nuevamente la oportunidad de poderlo presentar, es un tema de actualidad que toca en mayor o menor medida a todos los países del mundo, y lo que les voy a mencionar o lo que voy a tratar es sobre migraciones en países de Latinoamérica, una mirada desde la pediatría. Antes que todo me disculpo que la presentación sea en español, mi inglés es bastante básico, pero traté de traducir la mayoría de las diapositivas al inglés para que nos podamos entender. Estas son algunas de la ruta de navegación que vamos a tener, algunas generalidades sobre migraciones, la situación de la migración en países de Latinoamérica y el Caribe, que les adelanto que es bastante dramática. Sé que están en Europa con una ola fuerte de migración y aquí cada vez, en esta región, es cada vez peor. Y la situación, y una cosa bien alarmante y relativamente nueva, o por lo menos que se le está poniendo algo más de atención, es sobre la situación de niños migrantes y adolescentes. Cuando a un gobierno de turno, ¿sí? o al presidente o al equipo que está gobernando el país, le preguntan, ¿usted está en disposición de recibir inmigrantes en su país? Se vienen a la cabeza muchas ideas como aumento de las ayudas sociales, precariedad laboral, delincuencia, asesinatos, violación. La mayoría de ellas solo son mitos, y lo más probable es que la respuesta de ese encargado del gobierno sea no gracias, no los queremos. Y eso obviamente genera un conflicto entre los que quieren entrar al país y los que no quieren recibirlos. Después del horror que se vivió en la Segunda Guerra Mundial, hubo una reunión de varios países y aparecieron la proclamación o la promulgación de los derechos universales, derechos humanos universales, que han sido ratificados por la mayoría de los países del mundo. En el artículo 13 claramente se expresa que toda persona tiene derecho a circular libremente y elegir su residencia en el territorio de un estado. Toda persona tiene derecho a salir de cualquier país, incluso del propio, y regresar a su país. Entonces, este es probablemente el comienzo de muchos de los problemas, ¿sí? En que tenemos el derecho a migrar, sin embargo el país vecino no tiene ninguna obligación de recibirnos. Y eso genera conflicto que explica muchas de las conductas de ciertos países o de algunos países con respecto a la posición frente a la migración. Esta diapositiva simplemente es para mencionar que la epidemia o la pandemia más bien del coronavirus, del COVID-19, frenó un poco las migraciones, ¿cierto? La historia de cómo partió, todos lo sabemos, en diciembre del 2019 en China, en enero del 2020, el 30 de enero, la OMS declara epidemia como una emergencia de salud de preocupación internacional y el 11 de marzo del 2020 lo declara como pandemia. Esto disminuyó al cerrar las fronteras, obviamente, y al disminuir la movilidad, frenó la migración en cerca al 60%. Antes, prepandemia, los flujos de migración permanente hacia países de la OCDE, que entendamos que es un grupo de países económicamente privilegiados, ¿cierto? Donde la migración es bien fuerte porque la gente busca migrar hacia los sitios donde mejor calidad de vida tengan. Estos flujos o esta migración aumentó hasta 5.3 millones en 2019 y cifras similares en el 2017 y 2018. En el 2020, como les mencionaba, como producto de la pandemia, se cierran las fronteras internacionales y empiezan las cuarentenas, lo que hace disminuir en un 46% la migración en el primer semestre del 2020 y para el segundo semestre del 2020 la caída fue de un 72%, con un promedio más o menos de un 60%, lo que les había mencionado anteriormente. Es importante tener en cuenta algunos términos. El ser refugiado, ser migrante, el término no da lo mismo, ¿sí? Es diferente, como lo vamos a ver más adelante. Internacional para las migraciones define que un inmigrante es cualquier persona que se desplaza o se ha desplazado a través de una frontera internacional o dentro de un país, fuera de su lugar habitual de residencia, independientemente de su situación jurídica, carácter voluntario o involuntario del desplazamiento, las causas del desplazamiento o la duración de la estancia. Por otro lado, refugiado, la Organización Internacional de Migraciones la define como una persona que con fundados temores de ser perseguida por motivos de raza, religión, nacionalidad, pertenencia a determinados grupos sociales u opiniones políticas, se encuentra fuera del país de su nacionalidad y no pueda, o a causa de dichos temores, no quiera acogerse a la protección de tal país. Si uno analiza estas definiciones, entendamos que el migrar en general conlleva un grado de vulnerabilidad importante. Las personas que migran generalmente están buscando nuevas oportunidades, mejores oportunidades para ellos y para sus familias, que muchas veces desafortunadamente no las encuentran en el país de acogida. Y por lo tanto migrar entendiendo que no por turismo o por decisión, por una mejor calidad de vida, me refiero a ya la persona jubilada, pensionada, ¿cierto?, que se va a pasar sus últimos días a una isla paradisíaca. No es la mayoría, es un término es una posibilidad de emigrar también, pero no es la mayoría. Entendamos que la mayoría van a buscar mejores oportunidades que no las tienen en sus propios países. Y por lo tanto ellos salen con un viaje programado, ¿cierto?, con una idea de llegar a un punto que muchas veces, como les mencionaba, no lo logran. Sin embargo, si lo comparamos con el refugiado, es una persona que sale con lo opuesto, agarra su maleta y sus pocas cosas que tiene y sale corriendo porque probablemente teme por su vida, y eso conlleva un grado aún mayor de vulnerabilidad. Por lo tanto, el término no da lo mismo. Hay una gran diferencia entre ellos. Otra definición que uno podría mencionar y que a mí me gusta mucho porque refleja muchas cosas es que la inmigración es un viaje peligroso hacia una vida mejor. Desafortunadamente, en muchos casos es así. Esto lo traigo porque dice mucho de lo que es ser un refugiado. Este es un relato de un refugiado, un desplazado colombiano, y dice lo siguiente: cuando la violencia llegó, nos tocó dejar todo e irnos a la ciudad. Nunca nos imaginamos que el desplazamiento iba a ser un viaje sin retorno, sin punto de llegada. Nos movemos pero no avanzamos. Mirándolo en perspectiva, hemos estado en 3 lugares durante este viaje: la violencia ya en el campo antes de salir, la miseria de los barrios de invasión cuando nos desplazamos y el insomnio ahora que hemos regresado a lo que fue nuestro hogar. Uno nunca deja de ser desplazado, es una marca, una forma de vida. Realmente es impactante el relato y dice mucho en pocas palabras. En Colombia, hasta el 2020, habían 8.3 millones de desplazados en el mundo. Era uno de los países con mayor desplazados en el mundo. Más del 42% de estos desplazados eran niños y adolescentes. Revisando un poco sobre el impacto que tiene, que es indudable, que tiene el fenómeno migratorio, la migración de las personas, hice esta gráfica para mostrar algunos aspectos positivos y otros que no lo son tanto, pero que se puede tomar como una oportunidad. El primero de ellos, indudablemente, hay un incremento de la población en el país receptor como consecuencia de la inmigración, pero esto por sí solo no es malo. Es indudable que esto genera algunos inconvenientes, ¿cierto? Porque si llegan, no sé, 50.000 personas en pocas semanas, indudablemente genera una alteración en el país de acogida o en la región donde está acogiendo estos migrantes. Por otro lado, una de las ventajas que tiene es el intercambio de capital humano, gente generalmente capacitada que por diferentes condiciones de su país tuvieron que salir a buscar mejores oportunidades, que es un poco lo que ha pasado con los migrantes venezolanos, que en general están muy bien capacitados y la mayoría tienen educación técnica universitaria o universitaria completa. Obviamente, al aumentar la cantidad de personas en una región, aumenta la demanda de bienes y servicios. Yo siempre pongo el ejemplo hay una ciudad pequeña con 100.000 habitantes que tiene un acueducto que abastece adecuadamente a 100.000 habitantes, tiene un banco, tiene farmacias, tiene un hospital para atender a 100.000 personas, ¿cierto? Y de pronto llegan 50.000, indudablemente que va a haber problemas, pero también se puede tomar como una oportunidad para mejorar las condiciones de ese acueducto que abastecía a 100.000 personas, aumentar la capacidad hospitalaria para atender más personas. Obviamente esto lleva un tiempo, ¿cierto? Y debe haber una planificación. Sin embargo, yo prefiero tomarlo como una oportunidad y no como una amenaza. Hay un intercambio cultural que es evidente, un enriquecimiento del lenguaje a nivel de los niños, y eso está más que estudiado en países con un pobre vocabulario, ¿cierto? Un vocabulario muy restringido, la llegada de inmigrantes con nuevos términos y un uso adecuado del lenguaje enriquece muchísimo. Desafortunadamente todavía, a pesar de las leyes que salen en forma frecuente, todavía estamos viendo la explotación en las personas migrantes, porque generalmente vienen indocumentadas, están en forma irregular en el país, y bajo esa amenaza de si no haces lo que, o si no trabajas por esta plata que te estoy pagando, que es generalmente muy por debajo de lo que el mercado dispone, con la amenaza de te denuncio frente a la autoridad de migración, se tienen que someter, y eso realmente habla muy mal como sociedad de cómo estamos tratando a las personas que migran de sus países. Toda esta migración ha llevado a un concepto que lleva poco tiempo sobre una nueva estructura familiar, y esto se ha llamado familia transnacional. Me refiero a un ejemplo que se vivió aquí, o se vive aquí en Chile, donde en la década de los 90, finales de los 90, principios de la década del 2000, el flujo migratorio era principalmente de mujeres que provenían de Perú, que dejaban sus familias, sus hijos chicos, para venir a trabajar aquí a Chile, y mandaban pues remesa y mandaban el dinero y además con la esperanza de que algún día regresarían por sus hijos. Estos hijos, estas mujeres que llegan al país de acogida, ¿cierto? Forman su nueva familia, probablemente pareja, tienen nuevos hijos, y dejaron atrás una familia que quedaron estos niños chicos a cargo de los abuelos. Estos niños fueron creciendo y ya no podían ser manejados por los abuelos, y aumentó en algunas regiones la drogadicción, el alcoholismo y el suicidio entre adolescentes. Y esto se convirtió en un problema de salud pública bien importante. Lo otro es el desplazamiento, que esto es un mito. El desplazamiento, los migrantes desplazan a los nacionales en los trabajos. Se ha comprobado que no es que los desplacen, lo que pasa es que los trabajos que generalmente son precarios no los quiere hacer los nacionales, y se lo dejan a los inmigrantes. Y lo otro es que la migración ayuda a la expansión económica en el país, tanto en el país de acogida como en el país de donde provienen, ¿sí? Para algunos países en Centroamérica, sobre todo, las remesas que mandan los inmigrantes a sus países se convierte en una parte importante del Producto Interno Bruto. Y recordemos que los inmigrantes sí pagan impuestos cuando compran pan, cuando van al supermercado, compran lo que requieran ellos, están pagando IVA y por lo tanto pagan impuestos igual que todos los demás. Quise traer esta fotografía que realmente no quisiéramos volver a ver. Esto fue en el norte de Chile, donde una población ya cansada de ver inmigrantes en la calle, durmiendo en la calle, ocupando espacios públicos, ¿cierto? No encontraron nada mejor que hacer una fogata y le quemaron todo lo que tenían los inmigrantes y los desalojaron de las calles. Esto, o sea, se entiende el porqué, indudablemente no se puede aceptar y esto es una vergüenza como ser humano de que ocurran estas situaciones. En esta gráfica son 3 pirámides poblacionales en el 2023. La primera es de la población en el mundo, de la región de Latinoamérica y de Chile. En el mundo, si bien la base, que son los niños, ¿cierto?, está cada vez más acortada, todavía parece una pirámide si la comparamos con lo que pasa en Latinoamérica y principalmente en Chile, en que cada vez están naciendo menos niños y por las mejores condiciones de vida está viviendo más la gente, hay una sobrevida mayor. Por lo tanto, para que el sistema funcione, como lo vamos a ver más adelante, requerimos, ¿sí?, se necesita que nazcan más personas y esto puede ser una ventaja de recibir migrantes que tienen generalmente una tasa de fecundidad más alta. Como les mencionaba anteriormente, hemos pasado del quinquenio del 55 al 60, que había una tasa de fecundidad en Latinoamérica prácticamente 6 hijos por mujer. Hemos disminuido en el quinquenio 2015-2020 a 2.04 niños por mujer. Y se espera o se estima que para el quinquenio 2055-2060 sea menos de 2 hijos por mujer, lo cual afecta la tasa de recambio, que debería ser de 2.1 hijos por mujer. Lo ideal para que el sistema funcione es que 4 personas activas, ¿sí?, laboralmente sostengan a un jubilado. Sin embargo, se ha estimado que para el quinquenio 2025-2030 va a haber 1.8 activos para sostener a un retirado. Por lo tanto, probablemente el sistema no va a dar para mantener a los jubilados o a los pensionados, y eso va a ser un problema para muchos gobiernos. Esto es para mostrar solamente un poco más detallado las tasas de fecundidad en países de Latinoamérica. Esta es una publicación que hicimos, está en los archivos de pediatría del Uruguay en el 2023, sobre el tema que estoy tratando, que es la situación de la migración en países de Latinoamérica, y claramente se ve cómo va disminuyendo entre el 2011 y el 2021 las tasas de fecundidad en la mayoría de los países de Latinoamérica. Esta es una gráfica, dibujo, una lámina que es de la Organización Panamericana de la Salud, que a mí siempre me gusta mostrar cuando hablo del tema de migraciones y salud, que muestra algunas cosas que son realmente aberrantes y que deberíamos desterrar ya desde hace mucho rato. ¿Cómo afecta la pobreza? O sea, ¿cómo afecta la precariedad de los diferentes pueblos indígenas y afrodescendientes en los países? La pobreza indudablemente afecta muchísimo el ser urbano o rural, el grado de analfabetismo, ¿cierto? No tener, como se dice aquí, pitutos o ningún poder político de decisión. Y esto es realmente aberrante. El ser mujer ya conlleva un grado de vulnerabilidad importante y que ayuda a este aumento en la exclusión de una sociedad. El ser indígena o afrodescendiente, el tener un solo idioma y la discapacidad. Como en forma rápida, información que es importante conocer, porque probablemente ya la conocen ustedes, es sobre la situación de la migración a nivel del mundo. Para el 2020, 281 millones de personas vivían en un país diferente al suyo, y esto equivale al 3.6% de la población mundial. En otras palabras, uno de cada 30 personas en el mundo es un inmigrante internacional. 14.6% de estos migrantes son niños o adolescentes, que corresponde a más de 41 millones de personas. En otras palabras, uno de cada 8 migrantes es un menor de 19 años de edad. En América Latina se da el fenómeno, el principal flujo migratorio es desde países del sur de Latinoamérica hacia los países del norte, básicamente Estados Unidos y Canadá, pero este fenómeno ha ido cambiando probablemente por las restricciones impuestas por los países de Norteamérica, y el flujo ha aumentado en un nuevo fenómeno que se llama sur-sur, que es dentro de la región. Vale decir, países, por ejemplo, como Colombia, como Venezuela, migran hacia países como Chile, que es en el extremo del continente americano. El Programa de Naciones Unidas para el Desarrollo, PNUD, ha desarrollado un indicador, ¿sí? Que es el índice de desarrollo humano, para poder catalogar, por así decirlo, las diferentes regiones y países en cuanto, teniendo en cuenta algunos factores como la esperanza de vida, la tasa de alfabetización y el ingreso per cápita. Y los ha clasificado en desarrollo humano muy alto cuando los países o regiones están por encima de 0.8, desarrollo humano alto cuando están entre 0.7 y 0.8, desarrollo humano medio cuando los que se encuentran entre 0.5 y 0.7, y desarrollo humano bajo con una valoración inferior a 0.55. Lo que es el coeficiente de Gini, que es una medida de desigualdad de un país o de una región, estando los valores entre 0 y 1, siendo el 0 igualdad total y el 1 desigualdad total. De los archivos de pediatría del Uruguay que publicamos hace poco, en el 2023, se muestra la tasa neta de migración, el índice de desarrollo humano y el coeficiente de Gini de 20 países de Latinoamérica, y tenemos que Chile, Costa Rica y Panamá son los únicos países que tienen una tasa neta de migración positiva, Esto quiere decir que entran más personas a su país que las que salen, y todos los demás son países de emigrantes, o sea, salen más personas de las que entran a su país. Y esto coincide con los países con más alto índice de desarrollo humano. Recordemos de cuando está por encima de 0.8 es un índice de desarrollo humano alto para los 3 países de la región: Chile, Costa Rica y Panamá. Sin embargo, estos mismos países tienen un coeficiente de Gini por debajo, por encima de 0.4, que según Naciones Unidas ya lo considera como alarmante en cuanto a desigualdad. ¿Qué pasa con la migración en Chile? Y escogí Chile porque es el país que tiene la mayor migración en la región. Lo característico de los migrantes que llegan a Chile es que la mayoría son hombres, en un 51%, mujeres 49%, generalmente tienen menos embarazo adolescente que las nacionales, las mujeres que llegan, y las niñas que llegan, y tienen un mayor nivel educativo secundario y técnico universitario que los locales. Y esto es bien llamativo, sobre todo en la población migrante venezolana. Pero llegan a un país con un coeficiente de Gini, como lo vimos anteriormente, con una desigualdad importante que está muy por encima del promedio de los países OCDE, que está en 0.33. Es una noticia que apareció en febrero del 2023 que afecta, en que cada vez es más frecuente y afecta a una gran cantidad de niños, en que mueren 100 inmigrantes al tratar de llegar a Italia desde África, y resulta que como se estaban hundiendo, no tuvieron nada mejor que tirar a los niños al agua. Y realmente esto como sociedad nos afecta mucho y nos deja mucho que reflexionar. Y esto introduce sobre un nuevo tema que es sobre la cantidad de niños migrantes que están viajando solos, no acompañados, que es otra tragedia que tenemos que afrontar. Este es lo que les mencionaba, un nuevo tema que tenemos que abordar como países y como sociedades científicas dedicadas a la atención de los niños, que son los niños migrantes, niños, niñas y adolescentes migrantes no acompañados. El 14,6% de la población mundial que migra son niños, niñas y adolescentes. El porcentaje de niños no acompañados, migrantes no acompañados, crece cada día. Sin embargo, es muy difícil conseguir literatura sobre esto, en cuanto a cifras me refiero, porque es como transparentar que esto está sucediendo. Entonces es mucho más fácil tenerlo escondido y hacer el del avestruz, esconder la cabeza en la tierra y considerar que no está pasando nada, cuando realmente es una tragedia importante. En Latinoamérica hay un sector entre Colombia y en la cruzada hacia Centroamérica a través de Panamá, que es la selva del Darién. Son muchísimos los niños que están migrando a través de esta selva, con una mortalidad altísima. Y adolescentes son migrantes o refugiados en el mundo. 28 millones han sido desplazados de sus hogares por guerras y conflictos. Si pensamos en todo lo que está pasando en la franja de Gaza, en Ucrania, es importante tenerlo en cuenta. Esta es una tabla en el mismo artículo de los archivos de pediatría del Uruguay, donde se ven el porcentaje de migrantes en niños menores de 19 años entre el 2010 y 2020 en las diferentes regiones del mundo: África, Asia, América, Oceanía y Europa. Esta es una tabla que muestra la población migrante, el porcentaje de niños migrantes en los 20 países estudiados de Latinoamérica entre el 2010 y 2020, y se ve que se mantiene más o menos en algunos países, aumenta el porcentaje de niños que está migrando. Y esta es otra forma de presentar la gráfica, que de pronto es un poco más explicativa de la gráfica anterior. En Estados Unidos, para el 2019, 40.500 niños no acompañados fueron detenidos en Estados Unidos. Lo que se hace es que cuando llega el niño, lo que buscan es un familiar en el país de acogida, y familiar que generalmente nunca aparece porque lo más probable es que sea irregular y no se puede enfrentar a que o someter o arriesgar a que lo expulsen del país. Y este niño que viajó solo generalmente queda abandonado a manos del Estado. Y entendamos que estos niños viajando solos son vulnerables por el hecho de ser migrante, y mucho más aún por ser niños no acompañados, donde hay una desintegración familiar, hay un confinamiento y probablemente los detienen en sitios de acogida, entre comillas. Puede haber explotación sexual y abusos de todo tipo. Este es un lactante en uno de los sitios de acogida, entre comillas, en la frontera entre Estados Unidos y México. Yo creo que es importante que le demos vida nuevamente a la proclamación de los derechos de la infancia, que probablemente los conocemos, los sabemos, pero en muchas ocasiones no lo aplicamos como corresponde. Muchas gracias. Aquí les dejo alguna bibliografía de los datos que se mostraron. Y muchas gracias. Si tienen alguna pregunta, ahí están mis datos de contacto del mail. Y nuevamente quiero agradecer la posibilidad de compartir con ustedes estos temas. Muchas gracias. Y por último, quiero compartir con ustedes esta última diapositiva. Este es un libro que acabo de escribir y que está siendo publicado por la Facultad de Medicina de la Universidad de Chile, que habla sobre la atención de niños, niñas y adolescentes de los diversos grupos humanos. ¿Realmente somos diferentes? ¿Realmente existen diferencias entre los afrodescendientes, entre los asiáticos, europeos? El porqué de esas diferencias, y tratar de explicar un poco por qué se llegó a eso. Cuando tenga el link se los puedo hacer llegar. Muchas gracias.
I'm a senior research consultant and a member of the American Association of Healthcare Administrative Management, better known as AHAM, in the United States. I am involved in healthcare research and publication of several articles on key public health issues. I have made significant contributions to the field of global healthcare, including the United States healthcare quality improvement initiatives. The objective of this second World Congress on Global Healthcare Conferences is to explore advanced techniques in healthcare. Our objective of gathering here today is also to share knowledge on how to improve the global healthcare so that we can live a better, healthier life. I'm very excited to join you today via video Zoom presentation, and I'm hopeful that this will be a great experience for you all. The topic that I am presenting to you today is relevant to the objective of the Second World Congress Global Health Conference. The title of my presentation is Assessment of the United States Healthcare Providers and Patient Satisfaction with the Use of Telemedicine during the COVID-19 pandemic. Actually, in this video presentation, I will cover areas that include telemedicine, what is it, the background information of telemedicine, and overview of the global COVID-19 pandemic crisis. I will look at my research objective, methods, and research results. And I will finish off with my conclusion and discussion of significance of telemedicine and future use of telemedicine. So actually, what is telemedicine? That's a good question. Telemedicine is the digital tool that was used to control the wide spread of COVID-19 pandemic. Telemedicine is an electronic communication technology that was used to support care delivery when distance between providers and patients were necessary during the COVID-19 crisis. Telemedicine replaces a face-to-face inpatient visit because of the total lockdown. As we have known, during the COVID-19, there was the idea of locking people down to avoid the spreading of the disease. So telemedicine was actually the solution, which, like I said before, it replaces face-to-face inpatient visits. So medical services were provided remotely. The next slide would be, which I don't have it over here, is the background information of the global coronavirus pandemic crisis in the use of the telemedicine. The coronavirus COVID-19 pandemic began in December 2019 in a Chinese city called Wuhan and quickly spread across the world in 2020. The pandemic presents an unprecedented challenge to the global public health. It has caused deaths, frustration, and economic devastation. In today's figure, over 7 million people have died from COVID-19 in the world. COVID-19 pandemic has claimed more than 1 million lives in the United States. People were asked to self-quarantine. The lockdown has had serious mental and psychological implications on people. While people were quarantined, those patients with acute chronic conditions still required medical care and treatment. The question now is, how do we deal with this situation? An alternative way to care must be sorted. The alternative way to provide care is telemedicine. Telemedicine reduces the disease spread by allowing patients to receive care at the comfort of their homes. Let us look at the differences between telemedicine and telehealth. While telemedicine describes all clinical services that are performed to patients remotely, these services include patient diagnosis and patient monitoring. Telehealth. Telehealth telehealth, on the other hand, explain how services that include preventive services, health promotion, non-clinical services like training, administrative meetings, and continuing education. To facilitate the use of telemedicine, patients must have access to a good internet, a good computer, and a tablet or smartphone. How is telemedicine being used? Telemedicine allows medical professionals to monitor patients remotely from a far distance. Physicians use telemedicine remotely to manage patients with chronic diseases such as cardiovascular disease, cancer monitoring, lower chronic respiratory disease, and Parkinson's disease, PD. Virtual digital diagnosis and treatments were also performed by the United States National Emergency Telecritical Network, acronym as NCTRCN, to support rural hospitals during the coronavirus COVID-19 pandemic. I'm moving on to this, the third area that I'm exploring, which is my research objective and methods and result. The objective of the research presentation is basically to assess United States healthcare providers and patient satisfaction with the use of telemedicine during the COVID-19 pandemic crisis. The methods include the research use publications that address telemedicine and telehealth articles that existed before and after the outbreak of the coronavirus COVID-19 pandemic crisis. The result include data analysis, which suggested that in 2020, 83% of patients who used telemedicine during the pandemic had overall satisfaction with their visits. 76% of patients stated that the use of telemedicine removed transportation barriers in traveling to the clinic to see their doctors. 83% said the patients and physician communications was strong. 91% of patients who were using primary care services were satisfied with the use of video consultations. 86% of patients were happy with the telephone consultation. From the perspective of the healthcare providers, the reported outcomes, 37% of multiple specialties physicians of the integrated healthcare were comfortable with the use of the video telehealth. 65% of the physicians said the patient-provider relationships was unpaired, which means it was never been damaged. We have good relationship. They were also satisfied with the quality of video and describing it to be good enough for a medical visit. 54% noted that video visits save time. I'm moving to the clinical report outcomes, reported outcome. Patients who were undergoing urological surgeries treatments using telemedicine indicated that in-person follow-up was good. They said there was safety in the post-surgery telehealth care use. A better emergency room visit outcomes was reported. There were better outcomes in emergency evaluation. Now look at the differences between the demographics who are using the telemedicine. My research looked at the areas of number of people like Black people, Asian, and the individuals with disabilities. Among the Black people, we had like 26.31% Black people use telemedicine, 22.02% Asians use telehealth, 35.40 individuals with disabilities use telemedicine more than others, 27.63% age 80 use telemedicine, while 18.44% individuals age 18 to 24 years old use telemedicine during the COVID-19 pandemic. Before I move to the conclusion, let me quickly look at the differences between the advantages and disadvantages of telemedicine. In terms of the advantages of telemedicine, it can improve access to care. For example, in communities that lack access to health care, providers can use telemedicine to receive care so that people can receive care. It has a much better convenience when it is compared to in-person visits. It allows to receive care from the privacy of their room, of their home. In terms of the disadvantages, telehealth or telemedicine one of the disadvantages is that the over utilization of the telemedicine, since it is very convenient, people would like to take the advantage of using it as even though if they don't need it, they will use it. So that's one of the disadvantages. So another the setback is in telemedicine is that it may not be appropriate in treating all health cases, or it may not be equivalent to what the people need. So it is not advantageous because people will take the advantage of it. That's okay. They may not need it, but they would like to use it. So back to the conclusion. The result of this project highlights the significant wide use of telemedicine during the COVID-19 pandemic crisis. Telemedicine is an alternative way to provide care to patients during the coronavirus COVID-19 pandemic emergency. It serves a substitute to an in-person traditional visit. It limits physical contact, reducing exposure to COVID-19 virus. So it also shortens the wait time for scheduling appointments to receive care, and it cuts down patient traveling and expenses to receive care. Well, with the current reduction of the COVID-19 pandemic in the United States, there's an attempt of reducing the number of people using the telemedicine. It's only yesterday that it was announced on the TV that they can extend this the usage to another 2 years. So before this decree, the usage of telemedicine reduced to 5% of all outpatient visits. So patients are back to normal in using the in-person visit now. So physicians believe that the patient did not receive enough quality of care, so they decided that okay, using telemedicine might not be appropriate. That is what the medical people said. So that's the end of my presentation.